Yes, yes.
Good afternoon. A very, very warm welcome to all the delegates to the ICOG online certification course on pelvic floor. We are very grateful to Dr. Parul Kottavada, Chairman ICOG, Dr. Jaideep Tank, President FOGSI, Dr. Madhuri Patel, Secretary General FOGSI, Dr. Sarita Bhale Rao, Secretary ICOG, and today's Vice Chairperson ICOG, Dr. Sheila Mane, guests Dr. Alka Kriplani, Madam, and Dr. Parag Binewala, Chairman-elect ICOG, and to the series conveners, Dr. Charmila, Dr. Parag, and Dr. Sheila Mane, and all the conveners for this pelvic floor certification course, Dr. Suman Sinha, Dr. Kavita Barnwal, and Dr. Vidya Tobi. And I welcome all the delegates to this day 2 of the pelvic floor certification course. And I would like to request Parag Binewala to do the welcome address. Dr. Parag is a senior consultant at Pune and PG teacher and unit head at Kamla Nehru Hospital. He's the chairperson-elect of ICOG 2024.
Yeah, thank
we
you,
all
Niharika.
know you, sir. Welcome, and please
you.
address the gathering.
Yeah, good afternoon. I bring greetings from ICOG, and it's indeed a pleasure to welcome you all as a series convener and as a guest of honor today. Thank you, ICOG office bearers, for the opportunity. I must compliment the team who has put in efforts, Dr. Suman Sinha, Dr. Kavita Banwal, and Dr. Vidya Tobi, who's the ICOG Governing Council member, and of course, the three conveners, Niharika, Meera, and Meena. Urogynecology is something which is really interesting. It is an upcoming field, though we as Indians are, we are very much exposed to the vaginal surgeries, but with so many experts around, I'm sure it is going to be a great learning experience. My best wishes for the program, and thank you, ICOG office bearers, for giving me an opportunity to share dais with one of my most favorite, Dr. Alka Kriplani. Thank you very much.
Dr. Sarita Bhale Rao, madam. Request.
Listen. Dr. Sarita Bhale Rao, madam, has joined. So one word from her also.
Yes.
It's okay. It's okay. You go on. Don't worry.
Madam, one line only. Just bless us.
Yeah, no, I just want to say, I think yesterday was fantastic, and this program, we've had such superb attendance. It's amazing, and all credit goes to the hardworking conveners, coordinators. So I'm really very happy, and wish you all the best for today and tomorrow.
Thank you, madam.
Thank you so much, ma'am. Nilima, can I have the CV of Dr. Suman Sinha, please? Dr. Suman. I request Dr. Suman Sinha to introduce the chief guest for today's certification course, Dr. Alka Kriplani. Dr. Suman Sinha is a chairperson, Vaginal Surgeries Committee. All of us know, and she's the convener for this pelvic floor certification course. So welcome, Dr. Suman Sinha, madam. Kindly reintroduce Dr. Alka Kriplani, today's chief guest.
Thank you, Dr. Niharika, for the warm introduction. So I welcome and invite our chief guest, Professor Dr. Alka Kriplani, madam, who is bestowed with Padma Shri, which is one of the highest civilian award of the Republic of India for her distinguished services by President of India in 2015. Presently, madam is director and HOD OB-GYN in Paras Hospital at Gurugram. She is a great scholar, profound academician, and a person of substance. I am glad to be associated with her. She has been ex-professor and HOD OB-GYN in the prestigious Institute of AIIMS, Delhi. She had been head of so many organizations, which reflects her organizational skill. And there are numerous awards and accolades, which adds feather to her cap. Welcome, madam.
Thank you so much for such a crisp and lovely introduction. And it's an absolute pleasure to be here today. And I was watching your program. My God, each and every aspect of Urogyne has been covered. So I must congratulate Team FOGSI. I must congratulate Parag. and Parag will take over. I'm looking forward, Parag, for you to become, because you get along with everybody and you will do great. But ICOG is presently doing great work. Congratulations to Dr. Suman and Dr. Vidya Thobi, again my favorite, and Charmila. So you people have made such a wonderful program. What to say of Urogyne? From the now, life expectancy had increased, and 1/3 of women are supposed to have these Urogyne problems, rather more. Gone are the days when we all, knew patient aya prolapse vaginal hysterectomy with pelvic floor repair. Now there are so many, especially these urinary incontinence. It's a very, very specialized branch, and I think we all gynec need to go deep into it if we want to take care of our patients well. There are so many laparoscopic procedures, so many conservative procedures, pectopexy, sacrospinopexy, even revisiting Leforts and revisiting. I hope all these procedures are covered very nicely. And on the top of it, medication. Now, it is no longer a urologist domain. In busy practice, everybody just writes Mirabegron. That's not correct. There are so many drugs for so many different indications all over the world. These meshes are being banned. So we also have to devise non-foreign body, non-mesh surgical procedures, which are not very much, prevalent presently, although our seniors used to do so many, taking fasciolata, her own tissue. Native tissue repair needs to be concentrated again. Drug therapy, life expectancy has increased so much. Patients are becoming more aware. They don't want to live with incontinence and having smell of urine. So I congratulate each and every person who is part of this lovely ICOG CME, which is for 3 days and covering all aspects, medical, surgical. Kudos to you people. I wish you all the best. And I heard Sarita telling that there is very good attendance. Attendance has to be very good. People come for programs where they learn for their day-to-day management. And this is one of the best area for that. Thank you for the invitation and wish you all the best and grand success for this endeavor. Thank you.
Madam. Thank you so much.
Thank you so much, ma'am. Thank you
Thank
so
you,
much
madam.
for your
I really
blessings.
feel blessed.
Can I have the CV of Dr. Kavita? Now I would like to introduce Dr. Kavita, the second convener for today's program. Dr. Kavita is a senior consultant and laparoscopic surgeon at Samarpan Hospital, Munger. She is the present chairperson of Urogynec and Pelvic Floor Repair Committee, FOGSI. Welcome, Dr. Kavita. And it was a wonderful program yesterday on Urogynec. I request Dr. Kavita to introduce Dr. Sheila Mane, Vice Chairperson, ICOG.
Okay.
Madam
Thank
has
you,
not
Dr.
joined.
Niharika. So, thank you so much, respected Chief Guest Alka Kripalani Madam, and ICOG conveners, series convener Parag Viniwala Sir, Charmila Madam, Vaginal Surgery Committee Chairperson Dr. Suman Sinha Madam, Sarita Bhalera Madam, ICOG Secretary, and those who are present. I'm not able to see all of you. So, really, it's a great program for 3 days. So yesterday we had urogynecology and today we are having labs, and again tomorrow we'll have urogynecology. So I think after 3 days, most of us who have joined will be trained in urogynecology. So here I am to introduce Dr. Sheila Mane Madam, who is the Vice Chairperson ICOG. So she is a very known personality as a PPS lady, and she has served Bangalore Society of Organic Society as President, and also President of Menopause Society, ICOG Society, Bangalore. And she has got many awards, including Best Committee Award by Meru Darahan Sotia for Safe Motherhood Committee, and also recipient of Best Teacher Award for Dr. B.R. Ambedkar Medical College, and also MS Signature Award for Phenomenal Leadership Providing High. So I request with great honor Dr. Sheila B. Mane Madam to give blessings and say a few words. Sheila Madam is there?
Sheila ma'am has not joined, so we'll take her blessings as and when she joins. So now I would like to request Dr. Suman Sinha to give the preamble of this course today.
No, we have to introduce Dr. Parag also, no? Did you introduce? No.
Yes, ma'am, I did.
The one it is done.
Okay.
I have already spoken.
Okay. So Welcome once again and good evening, everyone. I take the honor to welcome all in the day second of ICOG online certificate course on pelvic floor. And today the topic of our study, which will be focused on genital prolapse, because it is one of the commonest distressing problem of women, and most of our women suffer silently. Cause can be damage to the anatomical or the physiological support of uterus, cervix, and vagina. The predisposing factor can be genetic, racial, childbirth, obesity, advancing age, menopause, and many more. Incidence is very high, it is around 40%. Our study is designed in such a manner that we can understand what is genital prolapse, how to diagnose it, what are the measures to prevent it, and how to manage it, either conservatively or surgically. So now, like previous day, we will have pre-test. 20 questions will be given and the participants will have 10 minutes to solve it. Link will be in the chat box or they can download it by QR code. And after all the sessions are over, you will have to appear for the post-test, which is based on the chapters which we will be discussing today. And I look forward to your participation. Thank you very much.
Thank you, Dr. Suman.
Guest.
Now I request the ICOG team to share the pre-test link in the PPT, and also the link will be shared in the chat box. So those of you who are using their mobiles can scan the PPT code and then do the pre-test. The pre-test time is only for 10 minutes, and you will be able to see the display on the screen. I think there's a question that somebody is not able to see it on this screen. And those of you who are logged in from their laptop, they can use the link from the chat box and open that and finish the pre-test.
ज्वाइन कीजिए ना भदी, स्टार्ट हो गया। हाँ, आपके व्हाट्सएप।
सुमन मैम आप म्यूटेड नहीं है।
You want me to unmute? Let me talk to Dr. Arma.
You have 5 more minutes for the pre-test. And once the time is over, you will not be able to submit it. You can have a look at the questions, but you may not be able to submit it once the timer goes off. But this pretest is only to give an idea of what the questions are there in the post test. It will be the same questions in the post test. So it's an idea for you to have a look at the PPTs and learn accordingly. Sheila Madam has joined, so we'll take the blessings right after the pre-test.
Yes, Madam, Dr. Sheila Mane has joined. Okay, Niharika, we'll take her blessings.
Yes, ma'am. Yes, ma'am. I've noted it.
No, if I talk now, they will be disturbed. Those people, those who are looking at the link. Shall we wait for that?
Yes, ma'am. After the pre-test only.
After the pre-test, yeah.
Our technical team is requested to unmute Dr. Abha Rani Sinha.
Done.
Yeah.
So the time for the pretest is over, and those of you who have joined in late and are accessing the pretest link now, you may not be able to submit, but you can have a look at the questions, and the questions will be same in the post-test. So we are very happy that Dr. Sheila Mane, Vice Chairperson ICOG, has joined, and she's already introduced. Madam, we would like to seek your blessings for this program. Over to you, Madam.
So good afternoon, everybody. And it's very nice to see the enthusiasm of everybody and the number of people who are attending. And I just congratulate all of you for putting up such an excellent scientific program. Okay, I know that first day has gone really very well, and many people had logged in. And today also, even in the beginning, we can see, I know that many people log in little later, but you know, almost about 200 people are here. And I would like to welcome all of you on behalf of BSOG. And I really thank all the conveners who have taken the, I must say, the attempt to frame this program and participate in this, making everybody aware about the pelvic floor dysfunction, as well as the medical and the surgical management. And I would like to welcome all the speakers today. Like we have Ajay Rane, Achila Batra, and that is, I think they have finished on.
That is day one.
Yeah. So now we have Dr. Sujata Dalvi, Lakshmi Shikhande, Archana, Rajeshri Paladi, Savita Rani, Nima Malhotra, Vidya Thobi, as well as Dr. Pradhan, Dr. Patnaik, and Dr. Rajendra Sarogi. I think so many seniors are also there. And I know, you know, I think particularly for this topic, I think you have both seniors as well as juniors. There are so many newer aspects. Yesterday they were discussed, and I think still you have to learn from the seniors, you know, because managing the prolapse and the pelvic floor dysfunction for such a long time. So it is an amalgamation of all the old age treatment, what was there, now the modern, and also the medication and everything. So once again, I welcome all of you and my best wishes for today's webinar. And thank you for giving me this opportunity to address the gathering today. Thank you.
Thank you.
Thank you. Thank you so much, Dr. Sheila Mane. So with that, we will move on to the academic session for day 2 of ICOG online certification course on pelvic floor. The pretest has been completed. Can I have the CVs of the chairpersons, please?
Sujata Dalvi, Madam, join.
Yes, everybody is here, ma'am.
Okay.
So I'm very happy to introduce the chairpersons for this first session. Dr. Abha Rani Sinha. She is the ICOG Governing Council member and was the president of Patna OB-GYN Society and was also the chairperson Quiz Committee FOGSI. Welcome, madam. Next we have Dr. Poonam Goel. She is the present chairperson of FOGSI Safe Motherhood Committee and ICOG Governing Council member and executive member of AOGD and EDGF. Many publications and awards to her credit too. Welcome, Dr. Poonam. Next, we have Dr. Vinita Singh. She's the Associate Professor at Department of OB-GYN at NMCH Patna and a consultant Kare Hospital and IVF Center. And at present, she is a Governing Council member of ICOG and the East Zone Coordinator for FOGSI. Welcome, Dr. Vinita. Now I request the chairpersons to introduce the first speaker of today's session, Dr. Sujata Dalvi. Over to you, chairpersons.
So good afternoon. It's my pleasure to introduce Dr. Sujata Dalvi, who is a consultant obstetrician and gynecologist from Mumbai. She has worked in prestigious hospitals like Gleneagles, Safi, Bhatia, St. Elizabeth, and she is at present honorary clinical associate of Naurozji Wadia Maternity Hospital. She is the treasurer of Mumbai Obstetrics and Gynecological Society and associate editor of Jogi. At present, she is president of Mumbai Menopause Society and immediate past secretary of FOGSI. So, Dr. Sujata Dalvi, I invite her to present her talk.
So thank you, Dr. Abarani Sinha, for a very kind introduction. Before I start sharing the screen, I would like to express my gratitude to ICOG Chair, Dr. Parul, ICOG Vice Chair, Dr. Sheila, and ICOG Secretary, Dr. Sarita Balera, for giving me an opportunity to speak on this subject in FOGSI ICOG certificate course on pelvic floor. So can I just share the screen? Yeah.
नड्डा जी का भाषण हो रहा है.
Yeah, so today my topic that is given to me is genitourinary syndrome of menopause. In short term, we call it as a GSM. What are the current practices? If you go to see, genitourinary syndrome is a chronic progressive condition of a vulvovaginal lower urinary tract characterized by broad spectrum. And that's the reason the name has been coined as GSM, that is genitourinary symptom of menopause. This name has been coined by International Society for Study of Women's Sexual Health and, of course, North American Menopause Society. And this is all related to decrease in the hormone leading to atrophic vaginal vaginitis and thereby leading to further symptoms. So it's basically the estrogen deficiency, which affects not only the vagina, but it also affects the bladder, urethra, and paravaginal connective tissue, because all these are lining very close to each other. So if you go to see, there are estrogen receptors even in the bladder, urethra, and trigone, which can lead to dysuria, urgency, incontinence, recurrent urinary tract infection, occasionally urethral prolapse, and even the ischemia of vesical trigone. It can also affect the vagina, uterosacral ligaments, levator ani, and puborectal muscles, thereby leading to what we call it as a vaginal wall prolapse. So before menopause, estrogen causes better trophicity in the epithelium and better vascularization, if you see on the left side, whereas after menopause, it causes closure of the pressing of the pressure of the bladder. There's less of vascularity and there's increased adrenergic receptors. So estrogen deficiency leads to lack of collagen in the vagina, thereby narrowing the vagina, and thereby it leads to dyspareunia. It also leads to atrophic bladder and the urethra, leading to urinary incontinence and, of course, urinary frequency. And that is all because of the estrogen deficiency which is present. Estrogen receptors, which are present in the bladder, trigone, urethra, they aid in increasing the sensory threshold when the bladder becomes distended. That is, when the bladder becomes distended, there is little bit of a sensory threshold, but women can still hold on. And bladder, even if the bladder continues to get distended, when there is lack of estrogen or decrease of estrogen, this decreases the sensory threshold and it decreases the urethral closing. And that's the reason it leads to what we call it as an urgency. That is, before even you reach the loo, you cannot hold on to the urine and there is a passage of urine, and that is all because of lack of estrogen. So far as a vulvovaginal atrophy is concerned, it leads to dyspareunia. And because it leads to dyspareunia, there are few non-prescription options. That is, one is to continue having a coital activity, whatever may be the frequency. To, in case patient is used to smoking, maybe cessation of smoking. Pelvic physiotherapy is of an immense importance in years of menopause. Lubricants or some moisturizers can be used whenever there is a sexual contact. If there is a prescription option that we have it, local estrogen therapy, if at all dyspareunia is of a greatest intensity, we do have oral medication which is available, known as an osmefifen. And then we have DHEA vaginal inserts, which are also available, which can be used provided non-prescription options do not work out for that particular patients. There are certain other options which are available, that is CO2 lasers, non-ablative YAG therapy. So basically, we do have other non-prescription sort of a thing, that is local phytoestrogens can be given. You can give oral vitamin D, you can give vaginal vitamin E, and even probiotics. That is in case they have other symptoms like vaginal infection or a vaginitis, which can lead to dyspareunia. So what about local estrogens, which we commonly use it for any patients who have dyspareunia and who has symptoms of a sexual, what we call it as a pain. So we have different routes of administration of a vaginal local estrogens which are available. There are vaginal creams which are available, that is 17 estradiol, 17 beta estradiol. We have a conjugated estrogens which is also available in the market, which can be initial stages. It can be used 3 times a week and later on maybe once a week, and later on one can reduce the frequency. There are vaginal tablets which are available, that is estradiol hemihydrate, that is Vagifem, which can be used once daily for about first 2 weeks when the symptoms are acute, and later on one can reduce it. There are vaginal capsules which are available. There are vaginal rings which are available, and of course oral you can give it, that is selective estrogen receptor modulators, or we, as what I said, osmevifen, which can be available and which can be used and which has not been yet available in India, but it has been used abroad and they have found good results with that. So these are the different options that we have it for patients who had dyspareunia because of an atrophic vaginitis. So estradiol vaginal cream, which is available, it is 2 to 4 milligrams daily. You can use it at least once in a day and gradually taper it to at least about 3 times a weekly till the symptomatic relief is there. Conjugated estrogens is also, cream is also available, which can be used intravaginally depending upon the severity of the condition, and then gradually taper it off maybe every alternate day and maybe then later on twice a week and once a week later on. Estriol cream is also available. That is one applicator. One can use it twice a weekly for at least about 6 months later on, maybe as in maintenance. So these are the different dosages of different creams which are available. What we have is a estrogen, with what we have is an estradiol and estriol which are available. Estradiol has got more affinity for sex hormone binding globulin, and that's the reason when this is used, it is less available, but it is more potent, whereas estriol, it does not stay long in the circulation. It does not bind to estrogen receptors strongly and not long enough, and that's the reason estrogenic effects are there, but there are less side effects with estriol, and that is the reason estriol action, it is more available, but it is little bit weak in action, but it is much safer as compared to estradiol. But that's because estradiol, it binds to sex hormone binding globulin. And later on, if it remains in the circulation for a little longer time, and if it is used for a little longer time, it can have little bit of a more side effects. What happens with the local estrogen therapy? Epithelium matures with the estrogen therapy. Absorption also increases, and that is the reason one has to start this therapy even before irreversible atrophic changes occur. That is, wherever, as soon as patients have some sort of a dyspareunia or some sort of a urinary, sexual pain or some pain at the time of having relations, and if this starts, then one can start using this therapy before it becomes irreversible and it causes lots of atrophic changes. And it's better to start off well on time so that patients have to use less of amount of dosage and for a less period of time. What happens if woman is on menopause hormone therapy for vasomotor symptoms, and if she still has what we call it as a genitourinary symptoms of menopause? Should we use local estrogens for these patients or no? Most of about 10 to 25% of the patients who are on MHT still may have urogenital atrophy, and these are the patients, they may not get relief with menopausal hormone therapy. So for these patients also, one can use local estrogen preparation only when they have acute symptoms, but low dose has to be given because she's already taking oral menopause hormone therapy, and that's the reason you need to give local estrogen therapy for an additional benefit effect till she has a relief. So it's not that you cannot give it, but the dosage has to be low, or the frequency of local application has to be a little less. How long can we continue using this local application? If it's a short-term interaction with alpha and beta receptors, it stimulates the superficial and intermediate cells of the vaginal epithelium. Per se, there is no change on the endometrium. So local therapy, it does not have any effect on the uterine endometrium. So one need not be worried about the proliferation of uterine endometrium. What it has is only the local effect only on the superficial and the intermediate cells of the vaginal epithelium, thereby making vagina a little more conducive, and that's the reason it does not lead to what we call it as an atrophic vaginitis. And this Cochrane review, it concludes that no study shows that however amount of local vaginal application of estrogen that we use it, It does not lead to endometrial proliferation even after 6 to 24 months of the use. That does not mean that we should prescribe this local estrogen therapy for a longer time. They can use it till they have an acute symptoms, and the moment the symptoms go off, they can gradually taper it off, and then maybe they can use what we call it as a non-prescription application of there are certain things which are available in the market for the same. So what are the relative contraindication? One is patient has history of breast cancer. If patient has history of endometrial cancer, patient has porphyria, patient if she has acute liver disease, hypertriglyceridemia, thromboembolic disorders, if there's an undiagnosed vaginal bleeding, occasionally endometriosis, and occasionally if patient has fibroids. These are little relative contraindications, but if a patient has acute symptoms and it does not get relief, maybe one can use local application for a short time just to wean it off over a little after a short time period, the moment patient gets relief. There are a group of women who may not get relief with local vaginal cream, and these are the women, they could still have some amount of pain. And why does this pain occur? What we call it as a decreased estrogen causes vestibular dynia, which affects about 10 to 16% of women in a postmenopausal age group. They do have a sharp burning pain localized over the lower part of the vagina or vulval vestibule, which are in response to the light pressure. That is, even if they're sitting, they do feel some amount of discomfort, and they are not able to even perform their activity well. These are the patients who are instructed to apply this vaginal gel containing 25 milligrams of estrogen only over the vulvar vestibular area, which can be administered daily over a period of 3 weeks, and then later on one can decrease it and one can continue up to about 12 weeks or so. After 12 weeks of therapy, they have found out that estrogen application have found a significant decrease in the mean score of dyspareunia so far as these patients are concerned. So even these patients who have a local vestibulodynia, these patients also get relief with a local estrogen therapy. What exactly is a vestibulodynia? There is a nerve plexus within the vaginal submucosa, which is composed only of sympathetic and parasympathetic axon, with smaller contribution by sensory fibers. And these are the nerve sensory fibers which are very dense and shallow, making this region little more sensitive. And that is the reason to make it little more insensitive or little less sensitive so that they do not have pain. Local application does have some sort of a role. And this explains that there is some amount of a coital pain which cannot reverse with estrogen. If you insert it in the vagina, it is insufficient to correct even severe vestibular allodynia. And these are the women, they will be treated, or they will have some sort of a relief if at all hydrating properties of a gel which has been used, which has a adequate for preventing vestibular discomfort. That is, there are certain gels which are available in the market, and because of the hydrating property, they are adequate for preventing vestibular discomfort rather than using the estrogen cream. What is the other option for patients who have dyspareunia is to increase the coital activity. This maintains the vaginal elasticity and sexual arousal, improving the vaginal lubrication, and this itself helps, and then patient need not use the vaginal estrogen cream. Smoking cessation is of an importance in case patient is used to smoking. Smoking increases the estrogen metabolism, and that's the reason they do have some sort of a symptoms because of lack of estrogen. So cessation of smoking, if at all it is feasible, would definitely help. Pelvic physiotherapy also helps in increasing vulvovaginal blood flow. It also helps in pelvic floor muscle function, and it helps in vulvovaginal tissue elasticity. Thereby also it helps in relieving the symptoms of dyspareunia. There are certain women, in spite of using all this, they do have some sort of a vaginal narrowness, and that is the reason these are the women that occasionally one might have to use vaginal dilators, which can improve the vaginal function. It helps in vaginal relaxation, which can be progressively adjusted to different size, but this has to be taught to the patient, and she has to introduce it herself slowly and gradually, and over a period of time, she has to increase the size of the vaginal dilators, and thereby whatever narrow vagina which is there, it helps in improving the dimension of the vagina and thereby relieving the dyspareunia. There are certain vaginal lubricants which have been recommended for subjective symptoms and improvement of a dyspareunia. This has been recommended by Indian Menopause Society guidelines. The ideal lubricant could be something which will have an osmolality of 380 milliosmoles. Upper limit of this could be about 1200, which is acceptable. Higher osmolality in the vaginal lubricant can irritate the vagina. Organic coconut oil, which is available in the market, has an osmolality between 180 to 340. And this is in total harmony with the body. So there are many patients who do get relief with just local application of the organic coconut oil.
Sorry to interrupt you, ma'am. Your time is up.
Yes. Lubricants can be comprised of water, silicone, natural oil, and petroleum base. So the ideal vaginal lubricant would be one which will have an increased glycerin, increased candidial. If there is an increased glycerol, it will lead to increased candidial growth, and that is the reason you need to have an ideal osmolality. These are the different preparations which are available in the market. One can suggest the patient to use it. What is the difference between moisturizers? So moisturizers are recommended whenever patients have vaginal dryness and dyspareunia, and this will hydrate the vaginal tissue and the vaginal epithelium, and this will relieve them of the symptoms. So it is beneficial for the women who have symptoms of vulvovaginal dyspareunia causing pain, increase in the sexual activity, and these vaginal moisturizers and the lubricants are of an immense importance. High hyaluronic acid vaginal gel can be used every 3 days, that is twice a week or even thrice a week. And these are the preparations which have been available in the market. Vaginal DHEA also has been studied, and they have used this given it for 3 months, and they have found little improvement in the symptoms of a dyspareunia for patient. And this is an oral 3rd generation SERMs which has been used for vulvovaginal symptoms, but right now it is still not available in India. As and when it is available, we'll get a fair idea about how this has been useful. But wherever it has been used, they found it to be quite useful for these patients, and it has been found to be a safe medication with minimal impact on the endometrium. That is of an importance. Laser therapy, these are all the cosmetic gynecological therapy. In case patients do not have relief, they can be used. And patients of a stress urinary incontinence will not be improving with the local vaginal estrogens, and these are the patients either a gynecologist can treat or even a urologist can treat. So this is all about patients with a stress urinary incontinence, and thank you for patient hearing.
Yeah, thank you, Dr. Sujata, for giving a very comprehensive view of genitourinary syndrome in menopause. I think you touched all the points, and this is the beauty of HRT, where local estrogen, it helps a lot in these women. And even sometimes with systemic estrogens, the patients, they are not relieved of the symptoms, and you need to add them. And you gave a very good practice point that we should give it in low dosage so that it works well. And even we are not afraid of the side effects. Apart from this, you touched all the recent advances like laser therapy, about the different osmorphine, which is not available, of course, in India, and of course, about the vaginal dilators, lubricants, their pros and cons. Everything was very well discussed, and I think it must be beneficial to all the participants who are listening to you today. Thank you so much, because the time is short, so I will not be talking much. Thank you so much. Thank you.
I think Lakshmi wanted to say something. She raised her
No, I
hand.
just say it's a very nice presentation, Sujata. Excellent.
Thank you, Dr.
Thank you, Dr.
Sujata
Lakshmi.
Dalvi. May I now request Dr. Poonam Goyal to introduce the next speaker, Dr. Lakshmi Srikhande.
She's not able to speak, so.
No issues.
Dr. Vinita?
Yes,
Dr.
yes, yes,
Vinita?
yes, 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 yes. The host has,
Nilima,
the
just
host had,
this is my old slide. Let me share my PPT. Yeah, just
okay, ma'am. I will introduce you. I have got your CV, ma'am.
No issues, no issues. I have
It's my privilege to introduce such a legendary person like Dr. Lakshmi Srikhande, ma'am. She is immediate past Chairperson ICOG, National Corresponding Editor Jogi, National Corresponding Secretary of Association of Medical Women of India, and she was past President of ISOPRAP Vidarbh chapter and member of Suffolk Education Committee. And there are many awards to her name. Nagpur Ratan Award from the she received it from Shri Nitin Gadkari ji and received Bharat Excellence Award, and she has delivered around, I think, 25 orations and 500 lectures and so many publications, and national as well as international to her credit. and it's a treat to listen to her. So welcome, ma'am. And
Thank
I
you.
must say, Dr. Sujata's talk was also
Yes, excellent.
very great.
Yeah.
Yes.
Can you all see my screen?
Yes, ma'am.
Welcome, ma'am.
Yeah. So friends,
Yes, ma'am.
topic given to me is approach to the prolapse, and you all know that this prolapse, it is the descent of pelvic structures into the vagina due to ligament or muscular weakness, and it is subcategorized according to the compartment, which I will be showing in next slide. And these can occur either singly or in combination. The etiology is multifactorial, but there is high correlation between pregnancy and vaginal delivery, which can lead to direct pelvic floor muscle and connective tissue injury. So I'm not going into the details of etiology. There are anatomical factors and there are clinical factors. Clinical, we have some predisposing factors, acquired and congenital, and we have aggravating factors. When it comes to compartment, we have anterior compartment defect, mid compartment defect, and posterior compartment defect, where we have enterosil as well as rectosil. Now, whenever you are approaching, that is, you want to evaluate, the first and foremost question in the assessment of pelvic organ prolapse is, what is significant pelvic organ descent? Because we know the mild degrees is seen even in young nulliparous women. So we should know what is the normality. And till date, we don't have this normality defined in the documents and guidelines. So for clinician, the first question is, what is significant pelvic organ descent? By which I mean the organ descent that is likely to cause symptoms of prolapse. And as prolapse is a relative indication for surgery, it is important for us clinicians to determine whether this degree of organ descent is relevant, whether the symptoms reported by patients are sufficiently explained by the examination findings in this particular patient, and we have to determine which compartment defect is most likely for these symptoms of the patient. So determining cutoffs is essential to define significant pelvic organ prolapse prior to surgical treatment. There are two primary mathematical approaches to define normality, and by using this mathematical approach, you can define the normality. Now the second step is differential diagnosis. You should be able to differentiate a cystosil from the Gartner duct cyst when we are talking of anterior compartment defect. When you are talking of mid compartment defect, the differential diagnosis of uterine prolapse should be remembered. That is congenital elongation of cervix, chronic inversion, fibroid polyp. And when we are talking of posterior compartment defect, we should be able to differentiate between enterosil and rectosil. Now, starting actual evaluation. We all know starts with the history taking. So history, it has to be started from the prolapse history. That is, what are the symptoms in the form of mechanical symptoms, the lump, the bulge, the obstruction, the pressure, or the history of backache. You have to ask urinary history, that is frequency, nocturia, urgency, stress, urge, voiding symptoms. Don't forget to ask for bowel symptoms, constipation, indigestion, fecal incontinence, sexual function history, obstetric, gynecological, surgical history, past medical history, comorbidities, and her BMI. These are very, very essential components of your history taking. Examination, do start with general examination, then abdominal examination, then pelvic examination, and then come to the ultrasound examination. Investigation, urine investigations are only required if patient is having urinary symptoms. When you are actually doing your PS or PV examination, see to it that her bladder is empty, and if possible, her rectum should also be empty. Patient of prosidentia can have decubitus ulcer and white discharge, but patients with pelvic organ prolapse, they have a high rate of coexisting pelvic floor disorders. 40% have urinary incontinence, 37% have overactive bladder, and 50% they have fecal incontinence. They should be routinely screened for alternative pathologies, and in many cases, prolapse can mask a hidden stress urinary incontinence. So you do need a systemic pelvic examination. What is adequate Valsalva maneuver? I am talking in my subsequent slides. When you are doing per speculum examination, I know there is a full talk on the staging, but remember that POP system staging you can do. This is the staging of pelvic organ prolapse, but this POP system also have certain drawbacks, that it is based on expert opinion rather than data. It provides information on surface anatomy only, and a moving structure, that is hymen, has been taken as the reference point. A urodynamic evaluation is recommended to assess bladder and sphincter function only if patient is having significant voiding symptoms. Apart from this basic evaluation which I have talked, the further evaluation depends on the patient's symptoms, the stage of prolapse, and your proposed treatment plan. Depending on that only, you should go ahead with complex urodynamic studies, and in some cases you have to do defecation proctography or dynamic MRI studies. Imaging has a very limited role in evaluating mild cases of pelvic prolapse that involve a single compartment or a single organ. But in complex cases involving multiple compartments and multiple pelvic organs, there is a dedicated talk again on imaging. One can go ahead with translabial ultrasound or MRI. MRI, of course, provides accurate assessment, better anatomical detail. It is useful as a preoperative tool, does not require bowel preparation, but it is not widely available and expensive. Translabial ultrasound will be talked in great detail in the subsequent talk. Now, don't forget to assess the integrity of the puborectalis muscle, which can be palpated by placing the index finger just lateral to the urethra, around 3 cm from the introitus on pelvic floor muscle contraction. A widened gap between the urethra and the muscle insertion may suggest levator avulsion. Now we all have come across the discrepancies between our preoperative assessment and intraoperative findings. And this is probably due to the false negative results on clinical examination and number of other different factors. Usually they are unrecognized and they may lead to an underestimation of pelvic organ descent. And this false negative is most likely to occur for the central compartment defect, where significant uterine descent is frequently missed on clinical examination. So as clinician, we should be aware of these co-founders. So levator coactivation, the triggering of a pelvic floor muscle contraction when asked to perform a Valsalva maneuver is levator coactivation, and this is an important co-founder of prolapse assessment. Assessment of pelvic organ descent, both clinically and on imaging, is undertaken based on the assumption that your patient is correctly performing the Valsalva maneuver. So what is this correctly performed Valsalva maneuver? Remember, this involves forced expiration against a closed glottis together with contraction of the diaphragm and abdominal muscles in order to markedly increase intra-abdominal pressure while relaxing the levator ani muscle. So a short push, which we often tell our patient, or 1 or 2 cuffs, they are obviously insufficient. Now, if we consider this pelvic organ prolapse to be a form of hernia through the levator hiatus, it becomes immediately apparent that there is competition for space between various pelvic organs. It is then not difficult to understand how this prolapse in one compartment may mask prolapse development in another. And prolapse recurrence is higher if we miss these concomitant other compartment defects. So significant uterine prolapse may occlude a rectovaginal septal defect, and hence it can mask the existence of a rectocele. So rectocele may be observed during the early stages of a Valsalva maneuver. I have already emphasized the importance of empty bladder and rectum. Now, whenever you are evaluating the patient, you are evaluating with the object of determining your treatment plan. So treatment plan is either conservative or surgery, and the third objective is whether you should go ahead and simultaneously do the continence surgery. So these are the indications for your conservative plan, that is the vaginal pessaries, because if your patient is unfit, unwilling, awaiting for surgery, if she's pregnant, if she's lactating, or you want your decubitus ulcer to heal, there are two types of pessaries, support pessaries and space filling pessaries. Now the second is surgery. Remember, the decision to do surgery depends on severity of symptoms and how prolapse is affecting her daily life. There are so many surgeries. Which type of surgery to be offered to that patient depends on the type of prolapse, symptoms, her age and her general health, her wish to have sexual intercourse, and whether or not she has completed her family. And if there is more than one choice, you have to discuss the pros and cons of each, and shared decision making is the norm. This is the algorithm for the surgery that can be reconstructive, obliterative, then according to the compartment. Now, whether you should go ahead and do concomitant USI surgery, if it is existing, yes, you have to do it. 13 to 65% of the women will develop urinary incontinence after surgery for prolapse. Preoperative testing, I have put a question mark. 40% of patients with negative testing, they will also develop post-operative stress urinary incontinence. So whether you should offer her prophylactic surgery in certain women who have stage 2 plus prolapse and they are having apical support surgery. But remember, when you are offering concomitant surgeries, the complication rates are higher. So to summarize, friends, whenever you are evaluating any case of pelvic organ prolapse, it starts with the detailed history taking. Don't forget to assess for the lower urinary tract function. This includes evaluation for urinary incontinence, whether it is stress or urge, and adequacy of bladder emptying. Assessment of bowel function is must. You have to ask whether she is straining at the time of passing stool using laxatives, there is fecal incontinence, or there is incomplete rectal emptying. Sexual assessment is very, very important, whether she is having dyspareunia, lack of sensation, and anorgasmia. Physical examination should include general and abdominal examination along with pars speculum and PV examination. Pelvic organ prolapse should be assessed as the woman performs the Valsalva maneuver, repetitive cuffing, or both. Presence and degree of prolapse should be recorded using a standardized POPQ or Baden-Walker system. Pelvic floor muscle activity should be assessed according to standardized formats such as the modified Oxford grading system. Assess the vaginal tissue for atrophic changes. Treatment is indicated only when patient is having bothersome bulge or pressure symptoms or sexual dysfunction, lower urinary tract dysfunction, or defecatory dysfunction. Proper diagnosis is a precondition for appropriate management, and surgical management should be individualized for each woman. Remember, the best surgical treatment, even in the hands of best surgeon, is likely to fail if it is performed for the wrong indication or on the wrong patient. And that is why correct approach to evaluation of pelvic organ prolapse is very, very important. Thank you, friends. Thank you for your patient hearing.
Thank you, Dr. Lakshmi, for such a nice, elaborate talk on such a, which we consider as such a simple thing, but actually it is that complicated that sometimes you are performing different surgery and patient is having a different problem. So assessment and doing the right job is very important. Thank you so much, ma'am.
Thank you. Thank you, Dr. Lakshmi, madam, and Dr. Poonam. I request Dr. Lakshmi and Dr. Sujata to answer the questions that the delegates have raised in the chat box. Please look into them. Now I request Dr. Vinita Singh to introduce the next speaker, Dr. Archana Kumari.
Thank you very much. Very good evening to all of you. After such a wonderful talk by Dr. Lakshmi Shikhande and Dr. Sujata Dalvi, I would like to introduce next speaker, Dr. Archana Kumari. We all know that now she is Chairperson-elect Quiz Committee FOGSI 2025 to 2027. She is Secretary Ranchi Obstetrician Society 2023 to 2025, E-Zone Coordinator Quiz Committee. She was Convener Clinical Research Committee, Organizing Secretary FOGSI E-Zone Conference with Yuva 2022 to Ranchi. We had experienced a very good conference. FOGSI Trainer for RSC and other Dhira FOGSI and led Manita Accessor. FOGSI UNICEF PCA Mentor for Lakshya Certification. And she has got so many academic achievements as teaching experience of 19 years and many awards to her accolades. So let us talk Archana Kumari. She is going to talk on very important topic, that is classification and etiology of uterine prolapse. So over to Dr. Archana.
Yeah, thank you, Vinita for that kind introduction. I will be sharing my screen. So I hope my screen is visible. I will put it in the slideshow mode.
Yes, ma'am. Yes.
Yes. So is it visible?
It is visible, ma'am. You can proceed.
Okay. So, so in next couple of 15 minutes, the outline of my talk would be something like this. After a brief introduction and knowing about the supports of uterus, we'll discuss about the etiology and risk factors. And of course, the topic is classification of prolapse. We'll discuss different types of grades of prolapse. And then we will discuss in detail about the POPQ classification. So this was already told by Lakshmi Madam, so I'm not going to repeat the definition. And of course, we know that prolapse is not a life-threatening condition, but associated with deterioration of quality of life. It is multifactorial in etiology, and it results from attenuation of all the supportive structures, whether it is muscle or fascia, tear or break, or by neuromuscular dysfunction. And it is very important to understand the 3 levels of pelvic support, because the different the break at the different level will cause different type of defects. So this slide is very, very important. The level 1 Delancey support is at the level of cervix and upper vagina, which is also referred to as suspensory axis, and this is provided by cardinal and uterosacral ligament. The defect will result in uterine prolapse, wall prolapse, or enterocele. Level 2 is at the level of the mid-vagina, which is also known as attachment axis. So anteriorly, there is a pubocervical fascia, and posteriorly, there is rectovaginal fascia. And laterally, there is attachment of the paravaginal fossa to the arcus tendinous fossa of pelvis. And this level defect will result in cystocele if it is anterior, and if it is posterior, it will result in rectocele. The level 3 is at the level of distal vagina, which is also known as fusion axis. So anteriorly, there is a urethra supported by pubourethral ligament, and posteriorly, there is a perineal body. The defect at this level will result in gaping introitus and urethral hypermobility. And the symptoms we can relate to these type of defect, which has already been elaborated by Lakshmi Madam elaborately. So coming to the etiopathogenesis, we all know childbirth trauma is the single most important factor, because damage to the pelvic floor or endopelvic fossa, the genital hiatus widens, and the pelvic organ gapes through that wide hiatus. Of course, the increase in intra-abdominal pressure can also lead to prolapse. So these are the various risk factors. I'm not going into detail, but multiparous women with shorter interpregnancy interval, prolonged second stage of labor, premature bearing down, forceps delivery, large birth weight infant are risk factors. And congenital weakness of the support can result in nulliparous type of prolapse, and often they have family history. The genetic disorder like Ehlers-Danlos syndrome and Marfan syndrome are, of course, rare causes of prolapse. The aggregating factor we all know could be menopause because of the hypoestrogenism, chronic cough, constipation, obesity, malnutrition, smoking, and occupation like heavyweight lifter and manual worker. Now coming to the classification of the prolapse. So traditionally, the pelvic organ prolapse has been classified on the basis of the anatomical deformity degree, the site of defect, and the presumed pelvic viscera that are involved. But there's a great intra and inter-observer variability in this, and it is difficult to compare successive examination in the same women or maybe in the same women over different period of time. So this is the traditional anatomical site prolapse classification, where you can see the term urethrocoele has been used because the underlying viscera is presumed to be urethra, cystocoele, uterovaginal prolapse, enterocoele, rectocoele. But the problem with disadvantage with this traditional classification is that there is uncertainty about actually what structure is lying behind the bulge. So this could be a false assumption, and therefore the term anterior vaginal wall prolapse, posterior vaginal wall prolapse, and apical prolapse are often preferred to these terminology. So this is the anatomical classification according to the vaginal wall. So you can see the anterior compartment defect. Again, it could be a cystocoele, urethrocoele, the apical compartment, which is also a middle compartment defect. It can be enterocoele, uterine prolapse, uterovaginal prolapse, vault prolapse in case of hysterectomized women. And posterior vaginal compartment can have rectocoele. Of course, enterocoele can be a part of I think there's some problem with the display.
Can't see your PPT, yeah.
What has happened?
Have a look.
What has happened?
Reshare.
My slides are not visible. Just let me check.
Yes, share once again.
Yeah, I will share it once again. So now it is here, no?
Yeah.
Am I audible? Yeah. So
yes, ma'am, you are visible and audible. Yes.
So this, I was talking that enterocoele could be a part of middle compartment defect, as well as it can be sometime posterior compartment defect as well. My slides are not moving now. Yeah. So this is again the traditional terminology which we need to discuss when students are listening. The cystocoele is descent of the upper two-thirds of the anterior vaginal wall because it carries base of bladder with it. Urethrocoele, descent of the lower one-third of the anterior vaginal wall with urethral displacement. Cystourethrocoele is prolapse of the whole of the anterior vaginal wall. And we need to know the grading of the cystocoele. Grade 1, when the bulge of the cystocoele is just into the vagina. When grade 2, it is up to the introitus or outlet on straining. Grade 3, bulge of the cystocoele is outside the vulvar outlet on straining, and grade 4, bulge is outside even without straining. And it is also very important to understand the difference between the central type of cystocoele and lateral type of cystocoele. Central defect is because of the loss of the midline vaginal fossa. So what happens? The vaginal rugosity is lost, but the lateral sulcus are preserved. And in lateral type of cystocoele, there is tear of the attachment of the vaginal fossa to ATFP. So lateral groove is lost, but rugosity is maintained. So, but this differentiation is not always seen. So now the middle compartment prolapse, uterovaginal prolapse, this is the most common type. It involves uterus, cervix, and vagina. Posterior vaginal prolapse can be an enterocoele, prolapse of the upper one-third of the posterior vaginal wall. And this is, in true sense, the true hernia of the pelvic floor disorders. Rectocoele is the posterior one-third prolapse, and this carries rectum with it. Lax perineum is torn perineal body, which produces gaping introitus. So these are the different types of classification and grading of prolapse. FOGSI classification is most commonly used for the teaching of undergraduate students. Of course, now we are also discussing Barden-Walker, Beecham 3 degrees classification, and the most talked about classification nowadays is POPQ, which is only internationally validated classification system of prolapse. FOGSI classification is simple. First degree, cervix lies below the normal level of ischial spine, but still above the introitus. Second degree, cervix lies at the introitus, but does not come out of the introitus. Third degree, cervix lies outside the introitus, but uterus is partially inside. Fourth degree, whole of the uterus with the fundus is outside. And this is the condition where we can approximate our thumb and index finger above the fundus of the body. So, and this is the Beecham 1980 theory degree classification. First degree, cervix and body of the uterus descend from the normal position, but it is still inside the vagina. Second degree, cervix come outside the introitus. but uterus is still within the vagina, and third degree complete eversion of the uterus with whole of the uterus lying outside the introitus. Now, this is Baden-Walker halfway system. This is second most commonly used system after POPQ. So here the grade 1 is descent of the most leading part of the prolapse halfway to the hymen, and grade 2 is descent up to the hymen, and grade 3 is descent halfway past the hymen, and grade 4 is the maximum descent. Now, this actually diagram represents the tridimensional anatomy being simplified into two-dimensional, and it signifies the 6 vaginal profile site of Baden-Walker system. I'm not going into detail, maybe I don't have that much time, so I will focus mainly on POPQ system. So this system was started by Bump et al. In 1996. It measures 9 distances, 6 vaginal points, AA and AB. They are the fixed point in the anterior vaginal wall, and they represents the anterior compartment. Then there are 2 points on the posterior vaginal wall, AP and BP, 2 points on the middle compartment, that is C and D. The 3 lengths are measured, which are genital hiatus, PB is perineal body, and tibial is the total vaginal length. And reference point for all the measurements are the hymenal margin. So this is the description of the 9-point detailed description. What is AA? This is a fixed point, 3 centimeter proximal to the external urethral meatus on the anterior vaginal wall, and it actually marks the uretrovesical junction. And BA is again, this is the most distal portion of the remaining upper part of the anterior vaginal wall. AP is again a fixed point on the posterior vaginal wall, 3 centimeter proximal to the external urethral meatus. BP is most distal portion of the remaining upper part of the posterior vaginal wall. C is the distal edge of the cervix, and in hysterectomized patient, it will correspond to the distal edge of the vaginal cuff. D is the location of the posterior fornix. That is, it marks the attachment of the uterosacral ligament, and it is not measured in hysterectomized patient. Now, the extent of A can vary from -3 to +3 centimeter. BA can vary from -3 to plus TVL. C and D will have value equal to ± total vaginal length. AP is a fixed point I already described. So this can vary from -3 to +3 again. BP can vary from -3 to plus TVL. And what about TVL? TVL is a total vaginal length, and this is actually it is measured according to the greatest depth of the vagina when cervix is reduced to its fullest position. Genital hiatus is the distance from the midpoint of the external urethral meatus to the posterior fortity, and it is in normal, if it is normal, it will measure 2 to 3 centimeter, whereas perineal body is the distance between the posterior fortity to the midpoint of the anus, and normal condition, it will measure 4 to 5 centimeter. So after measurement, we have to create this 9-point grid, and accordingly, we will do the POPQ staging. So stage 1 is the leading portion of the prolapse is more than 1 centimeter above the level of the hymen. Stage 2 is when most distal part of the prolapse is within 1 centimeter or distal 1 centimeter of the hymen. And stage 3 is most distal part of the prolapse is more than 1 centimeter below the plane of the hymen, but less than TVL -2 centimeter. And stage 4 is complete eversion of the vagina. The most distal portion of the prolapse protrudes beyond TVL -2 centimeter. I will make it more clear with the diagrams. You can see here, this is the stage 1 prolapse where the most distal edge of the prolapse is below, between TVL but it is above 1 centimeter above the hymen. This is stage 2 prolapse where you can see the leading portion of the prolapse is between 1 centimeter proximal to the hymen and 1 centimeter distal to the hymen. Stage 3, you can see the leading portion of the prolapse has gone beyond 1 centimeter of the hymen, but it is still less than TVL -2. And stage 4, the most leading portion of the prolapse is beyond TVL -2 centimeter. So this is the comparison of the commonly used grading system. So you can see it is the comparison of the Baden-Walker, the BCAM grading system and the POPQ grading system. The difference you can note in here, the reference point is introitus in this system, but in POPQ, the reference point is hymen. So this can make a difference in staging. Recently, a simplified POPQ classification has been evaluated in 2006. The staging is similar to POPQ, but there are only 4 measurements we are taking. 1 point on the anterior vaginal wall is the BA, and 1 point on the posterior vaginal wall is BP. And then you take C as the distal edge of the cervix and D, the posterior fornix. So this is the simplified POPQ classification, this one. And you can see the staging of this simplified POPQ is similar to the original POPQ devised in 1996. And now I'll come to the most important part of my presentation, how to demonstrate POPQ staging, because this is the part which the resident really feel very difficult to understand and to demonstrate. But they are supposed to make the grid and line diagram if they get a case of uterovaginal prolapse in exam. So the principles are very, very simple. All measurements are taken in Valsalva except total vaginal length. The reference point for all measurements are hymenal margin, actually. And we have to measure the leading point of the prolapse. Total vaginal length is measured from vaginal apex to the hymen after reduction. All measurements inside vagina are negative and all measurements outside are positive. These are the instruments which we require. And the patient has to be placed in dorsal lithotomy position. She will be doing Valsalva maneuver, as Lakshmi Madam has told. She has to exert a lot. And we start measuring with GH, that is genital hiatus and perineal body. But the problem is that if the patient starts pushing, how to measure genital hiatus? Just before the cervix comes outside, you measure this distance from the external urethral meatus to the midpoint of the posterior fourchette, and similarly you measure perineal body. Then you ask the patient to relax and measure TVL. So this is in the diagram, you can see this is the measurement of genital hiatus, this is perineal body, and after reducing the prolapse to full extent, we measure the total vaginal length and mark it on the grid. Then next is, we have already marked point AA on the anterior vaginal wall. So we are measuring AA and AP, and you enter it into the grid. Next, you measure point AP and BP, and then C and D. Of course, when C is outside, the cervix is outside the introitus, we don't need to use Cusco speculum, but if cervix is inside, we have to use Cusco speculum to measure it. And then we measure D and we enter all the points into the grid. One very important point I would like to discuss here is, here C is plus 3.5, but D is minus 7. It is quite inside the vagina. So what does it signify? It signifies cervical elongation. This means that point D, which is the position of the uterosacral ligament attachment, there is good suspensory support. It is just the cervical elongation. And this is the line diagram corresponding to the complete eversion of the vagina. This is the grid and line diagram of predominant.
I'm sorry to interrupt you. Your time is up.
Just 1 minute, I'm finishing. And this is the predominant posterior vaginal wall prolapse. So this is a simple case where a 58 years woman comes with these measurements. So you can see we have to stage the prolapse here. So how we have to look at the maximum descent point is plus 6, and this is less than 2 centimeter of minus TVL. TVL is 10, so it is less than 8 centimeter. So this stage would be stage 3. So this is what I wanted to highlight, although because of shortage of time, I might not have done justice to this. But and I'll just skip the pros and cons a little bit about it. Already Lakshmi Madam told. Advantage is that it is objective, site-specific and scientific method. So inter-observer variation is less. Everything is measured in numbers, but the disadvantage, it is little time-consuming and complicated. Site-specific defects are not measured. The dynamic point, hymen is taken as the reference point. So these are the key points. I'm just going to skip this. Thank you so much.
Thank you, Archana. In fact, I was, mesmerized by the clear concept you have given regarding POPQ classification. That was really very good. And since our post-graduation, we were so, it was so important that we should know the classification etiopathogenesis. We all know that childbirth trauma is also a contributory factor. In that, we always say that after full dilatation, only bear down should be there. So don't ask the female to bear down before there is full dilatation is not there. And we have given a very elaborate talk on this 3-tier pelvic support. That's really very good. So once again, thank you very much, Archana, for giving such a wonderful talk. Thank you.
Thank you.
Thank you, Dr. Vinita Singh and Dr. Archana. May I now to introduce the next speaker, Dr. Rajeshri Pala. Have her CV, please.
Shall I introduce?
Yes, ma'am. Yes, ma'am. You can.
Okay, so the next speaker is done, but Dr. Rajeshri Paladi, and she is going to speak on clinical features, diagnosis, and prevention of prolapse. Since her screen is, CV is not. Can you share her CV?
Please make it full screen.
So, yeah, can I make it full screen? She is on. It's not visible, dear. Can I make it more? Yeah, now it's okay.
Ma'am, now
so
it
Dr.
is.
Rajeshri, yeah, it's okay. So she is the Honorable Secretary of Karnataka State Obstetric and Gynecological Association, and she also Dean of Research, KBR University, and she is member of IQAC. She is member of Academic Council, KBR University, and Professor Department of Obsangani, this Kala Buragi, KBNIMS College, and she is postgraduate and undergraduate examiner at various universities and presented so many papers and guest lectures at various forums. So over to you, Rajeshri.
Pranams. Extremely grateful to the ICOG team headed by Dr. Parul as the chair and Dr. Sheila Mane as the vice chair for having given me an opportunity to share this dais. Given a topic after such giants of the field having presented so very well, Dr. Sujata Dalvi, Dr. Lakshmi Srikhande, and Dr. Archana Kumari. I'm now talking about the clinical features, diagnosis, and prevention of prolapse. Thanks for the kind words of introduction. And next. We know that the pelvic floor dysfunction is a common problem that leads to significant suffering among the women. And as has been told, childbirth trauma is the most important factor which leads to the pelvic floor dysfunction, which requires surgical correction in many times. And it affects over millions of people worldwide. And it's the third common indication for hysterectomy in the US alone. The woman having a cumulative lifetime risk of 12% to undergo the surgery or after pelvic organ prolapse. And based on the patient symptoms, there is a prevalence ranging from 3 to 6% in the United States. And based on the clinical examination alone, the prevalence of pelvic organ prolapse could be to the tune of 30 to 60% in India. And based on the symptoms, it is very less, going to show that the symptoms may be very less even in an advanced stage of prolapse. The risk increases by childbirth, as we know, and 1.2 times after each childbirth. One delivery, 2.8 times risk. After 2 deliveries, 4.1 times risk, and 5.3 times risk with previous 3 vaginal deliveries. The pelvic floor disorders consists of the urinary incontinence, the fecal incontinence, or the pelvic organ prolapse. And the prevalence of pelvic floor dysfunction is estimated to range between 12 to 42%. The symptoms can present as early as 20 years, and the prevalence increases with age, and they're most often seen in late adulthood. So the clinical features, diagnosis, and prevention. The descent of one or more of the anterior vaginal wall, posterior vaginal wall, uterus and cervix, and the vaginal apex or the perineum. Thereby, accurate anatomical knowledge helps us to understand the nature of the pelvic floor dysfunction. The discomfort and inconvenience experienced by the patient is extremely variable. So just based on the symptoms, the incidence is considerably less. The complete procedentia may exist for many years without any serious incapacitation. Moderate degree of uterine or vaginal descent will sometimes cause severe kind of discomfort, and the difference may be in part explained by the basis of the resistance which is offered by the supporting ligaments. Little resistance, as in gross uterovaginal collapse, has little discomfort because the entire organ has just collapsed down, and only a few of the following possible symptoms are seen in some women. The characteristic features is most of the symptoms are relieved on lying down. So the symptoms could be urinary, as in the urinary incontinence or increased urinary frequency, urgency, weak or prolonged urinary system, hesitancy, feeling of incomplete emptying, and manual reduction of prolapse to start the complete voiding. This is classically seen as in procedentia, and position change to start or complete the voiding, as is evident when we take upon the history and import that the patient always says that only on repositioning it back, she's able to empty it completely. There could be bowel symptoms as incontinence or flatus for liquid or solid stool, feeling of incomplete emptying of the stools, hard straining to defecate, urgency to defecate, digital evacuation to complete the defecation, or splinting of the vagina or perineum to start or complete the defecation, and feeling of blockage or obstruction during the defecation. As a result of the bulge, there could be a sensation of the vaginal bulging or protrusion in between the thighs, and seeing or feeling of a vaginal or perineal bulge, the pelvic or vaginal pressure, and heaviness in the pelvis or vagina. Most often, the patient may have dyspareunia. There could be decreased lubrication because of the constant exposure of the vaginal mucosa, the decreased sensation, and decreased arousal or orgasm, which could also be associated with the pain in the vagina, bladder or rectum, and pelvic pain or low backache. So on examination, what do we see is that does the protrusion come beyond the hymen? What is the presenting part of the prolapse? If it is the anterior, posterior, or apical, and does the genital hiatus significantly widen with increased abdominal pressure? The previous speakers, Dr. Archana Kumari and Dr. Lakshmi, have quite extensively spoken about these features. But the basic thing when we try to evaluate the patient is as she steps into the OPD, when we know that we are dealing with such a case, is to look for the BMI, look at the neuromuscular issues, whether there is any discrepancy in her walk, supraclavicular lymph nodes to rule out any chronic conditions like chest disorders, auscultate the chest, look for ascites and abdominal mass to look if there are any pressure symptoms leading to prolapse. So in the physical examination, it is mandatory to ask the patient to empty the bladder and make her lie down in the lithotomy position. The vulva perineum are examined for signs of vulval or vaginal atrophy, introitus for gaping, and each compartment is evaluated while the patient performs the Valsalva manner, and full extent of the prolapse can be ascertained by looking. Inconsistent finding of the patient's description of her symptoms, perform a standing straining examination with the bladder empty. This becomes very useful in diagnosing the grade. So on inspection, look for the health, the excoriation, redness, inflammation, and description of the mass based on the size, shape, and cough impulse. Look for stress incontinence or ulceration and keratinization of the mass. On palpation, to confirm the position and presence of the external os, it helps to find out whether there is an anterior or a posterior defect based on the position, and to grade the prolapse based on the different classifications that we have, and ulceration or bleeding on touch. Then speculum examination is very, very important, as we have seen even in the POCU classification or other grades of classification, to know the cystocele grade, to see for the lateral or central cystocele, the degree of the uterine descent, the enterocele, and the rectocele. So anterior compartment examination to be done by retracting the posterior vaginal wall and cervix by the Sims, visualization of the anterior vaginal wall, bulging, and when middle part of the posterior vaginal bulge, that is rectocele, to be noted, and bulge in the upper part, that is enterocele, and when prolapse is pressed, a gurgling sound is heard in the enterocele. Next point is not to forget about the bimanual pelvic examination to look for the cervical elongation, the mobility and size of the uterus, to look for the fornicel masses and the levator tone or the perineal body size and thickness. Neurological examination of the sacral reflexes, what is known as the bulbocavernosus reflex or the anal wind reflex, helps to understand the intactness of the spinal cord, and the Boney's test, that is eliciting the stress incontinence, indicated when there is a positive stress test associated with the cystocele, to know if incontinence is due to descent of the bladder neck or weakness of the sphincter. The index and the middle fingers are placed on both sides of the urethra to elevate the bladder. neck upwards, and if no urine escapes on stress, it means that the incontinence is due to the descent of the bladder neck. If urine still escapes out, it means that there is a weakness of the sphincter. And a rectal examination to know the skin of the perineum, the anal sphincter inspected, skin creases seen, patient is asked to squeeze, and perineal descent and rectal prolapse are checked by asking the woman to strain. The index finger is placed 1 to 3 centimeters inside the hymen at 4 and then 8 o'clock position, and the muscle resting tone and strength is assessed using through the grading through 0 to 5. Oxford grading scale, in which 5 represent a normal tone and strength of the muscle. So this diagram shows how the index finger is placed inside the hymen. So many systems for staging prolapse have been described, and typically it is graded on the scale of 0 to 3 or 0 to 4, with the grade increasing with severity of the prolapse. As has been extensively discussed, the current system approved by the International Continence Society is the pelvic POP classification, which is used, and this is the standardization of terminology of the female pelvic prolapse and dysfunction as quoted in the American Journal of Obstetrics and Gynecology in 1996. The International Continence Society defined a system of POP, and this has been told very nicely by my previous speaker, Dr. Archana Kumari, which I'm going to skip. So the normal pelvic anatomy, we know the diagram shows this. In the anterior vaginal wall prolapse or a cystocele, there is a descent of the anterior vaginal wall. Posterior wall, there is a descent, and then apical or the vault prolapse. So the diameter of the genital hiatus is noted. The pubic width of the perineal body is noted, and the total vaginal length are measured and recorded. So anterior vaginal points, the point AA, point BA, the posterior vaginal points, the point AP, the point BP. And I think this we need to memorize and by heart. As amount of time that is described, it again evaporates away, and Dr. Archana has very nicely told the points. The point C defines a point that is either the most distal of the cervix or the leading edge of the vaginal cuff after total hysterectomy. And point D defines a point that represents the location of the posterior fornix. So there could be possible ranges which will help us to diagnose adequately and accurately to a large extent, so that this diagnosis is mandatory before we undertake the patient for any surgical correction. So the stages of pelvic organ prolapse, stage 0 through stage 4, wherein the stage 4 is complete to nearly complete eversion of the vagina, and the most distal portion, the end of the prolapse protrudes to greater than 2 centimeters beyond the hymen. So other classifications are the Shaw's classification, the Baden and Walker-Hoffman system, and the Jeffcott's and Malpass classification. These are necessary to know how to manage the case and to what extent we are going to offer the surgical corrections to this patient. I'm skipping this because it has been already covered. Jeffcott classification, that is the uterovaginal prolapse or the complete precedentia, the vaginal wall prolapse, which has the anterior cystocele, urethrocoele, and the posterior enterocele, rectocele, wall prolapse, nulliparous prolapse, and post-hysterectomy prolapse. The Malpass classification. So we need to understand that prevention is better than cure. So the role of pelvic physiotherapy in pelvic floor dysfunction is now established as the first-line treatment for prevention of pelvic organ prolapse. Prevention, first, it would be the lifestyle changes to maintain the normal BMI, to avoid any habits like smoking, avoid chronic cough by giving adequate treatment measures, and avoid constipation, avoid lifting heavy weight, avoid physical activity that impacts on the pelvic floor like running or trampolining. Adequate antenatal and intranatal care goes beyond any kind of doubt that providing the good care during the intrapartum phase is the most important factor in preventing the prolapse, to avoid injury to the supporting structures during the time of vaginal delivery, either spontaneous or instrumental delivery, and adequate postnatal care, to encourage the early ambulation and encourage pelvic floor exercises post-delivery. The pelvic floor exercises may not rid of the prolapse but are likely to improve the symptoms, and even if surgical treatment is considered, it is advisable to continue the pelvic floor muscle training and to improve the overall chance of successful treatment by surgery. The Kegels exercise most commonly advocated, the contract and upward liftment of the pelvic area. Hold the contraction and then release the contraction and give a pause. How to perform the pelvic floor exercise? Locate the pelvic floor muscles, squeeze the pelvic floor muscles as tightly as possible for a few seconds to maximum of 10 to 15 seconds. Relax completely for at least 10 to 15 seconds. And again, repeat as recommended by the physician or continence advisor. So that is what is about the Kegels exercise. So This is what is about the pelvic floor muscles, which has been so extensively discussed. And I think it is the erect posture of the human which is responsible for the prolapse of the uterus. Life of an individual is controlled by the programs that run in the unconscious mind. So we have to program ourselves to deal with the prolapse adequately. Thank you all for the patient hearing.
Thank you. Thank you, Dr. Rajeshri Palladi, for a wonderful talk. Can we have some comments from the chairpersons?
Dr. Vinita has already left. Can we see any other chairperson?
Okay. So anyway, I think running a little late as per schedule also. So thank you all the
chairpersons. A very
chairpersons.
nice presentation, Dr. Rajeshri. I wanted to give one comment at least. All postpartum female, whenever they come to us for checkup, even for some different reason, we must ask leading question regarding is there something coming down their vagina? Because they will not tell and they will suffer silently. So that is the right time where you tell them what are the conservative methods. They can do the Kegels exercise and other pelvic floor muscle exercises, and that will again she can go back to what was she before her pregnancy. So that is very important. We have to take under our control so that our women, they don't suffer. And so really, it was very nice presentation, rather a nice treat.
Add something?
Yeah, ma'am.
Thank you, ma'am.
Yeah, there's just new devices which have come up because the Kegel exercises, easy said than done. They are very difficult to do. So now we have high intensity focused electromagnetic chairs available. They are costly, but they are effective quite because they are giving per minute 10 to 15,000 contractions are there, 10 to 12,000 contractions.
Early prolapse can be treated also with that.
Yeah.
And
so
if it is associated with urinary incontinence, this
lasers and everything is coming up, I think, which can be used again. Thank you.
Yes. And also RF is also doing very well in case of stress urinary incontinence. So it's very good. Laser
energy
and RF
devices,
is very good.
Energy devices are lasers.
Yes, energy devices
RF
is also very good. I'm
devices,
using that.
and
Yeah,
then
I'm
high
using that. It's
electricity.
really very good. Yeah.
Yes.
It's very good. So thank you, Rashi. It was
Thank you,
really a
ma'am.
wonderful talk. Wonderful talk, dear.
Thank you, ma'am.
Thank you for the input, persons, Dr. Maninder. I thank all the speakers. We've spoken about energy devices yesterday. Dr. Narendra Malhotra has taken a session on that, madam. And with that, we've come to the end of the first session. Now, let us go to the second session. And I would like to welcome. Are you able to see my screen?
Yes.
Yes, let me just. So I would like to welcome the chairpersons for the second session, Dr. Haresh Doshi. He's a professor and HOD of Obstetrics and Gynecology at Medical College. Sir has been the chairperson of Practical Obstetrics Committee, FOGSI, from 2004 to 2008. In 2019, he had many publications to his credit, and he's been a faculty across the country and internationally. Welcome, Dr. Harish. Next, Janmajaya Mahapatra. Sir is presently working in Odisha as an associate professor in Department of Gynec Oncology. He's the present vice president of FOGSI 2024. As the chairperson, Clinical Research Committee of FOGSI in 2013 and 15. And Sir has served as in various capacities across his illustrious tenure and many awards. Welcome, sir. Next, we have Dr. Pratik Tambe. He is an ART consultant from Mumbai. He's the governing council member of ICOG and ICRM, and also served as the chairperson FOGSI Endocrinology Committee from 2017 and chairperson of AMOX Endocrinology Committee from 2020 to 24 now. So welcome, Dr. With that, I hand over the session to the chairpersons, and I request the chairpersons to introduce the first speaker of this session, Dr. Savita Rani Singh.
Can I introduce? Hello.
Yes, sir.
Yes, sir. Please go ahead, sir.
Yes, sir. Thank you, Dr.
You are the
Pratik.
senior most.
Yeah. I must thank FOGSI office bearers, Dr. Tank and Dr. Madhuri Patel, and ICOG Chairperson Parul, Vice Chairperson Dr. Sheila Mane, and Secretary Dr. Sarita, also series convener Dr. Parag and Charmila, also convener of this series Dr. Kavita Madam, Dr. Suman Madam, Vidya Madam, and also coordinators of this program, right? Meera Madam, Neharika Madam, and Meena Madam. And my co-chairpersons, right, that is Dr. Janmejay, Vice President, and great Dr. Pratik Tambe. Well, I have a pleasant duty to introduce Dr. Savita Rani Singhal. This is the second session of the second day, mainly concerned with the prolapse of uterus. And we had all these clinical features and definition and right classification. Now we have three interesting topics. The first topic will be by Dr. Savita Rani Singhal. She will be discussing on the right conservative treatment of prolapse. She is professor for 10 years, senior professor 8 years, PGIMS Rohtak. Teachers is 35 years, various position, right, at various association, right, in FOGSI and local level, 220 national and international publication, over 100 guest lectures, right, and many, many awards. Great faculty indeed, stalwart. Please, Dr. Savita Rani, Madam, please start your presentation.
Yeah, thank you, Dr. Doshi, for the kind words. And at the outset, I thank the organizers, Dr. Suman, for giving me this opportunity. I'm trying to share my slides. And are my slides visible?
Not yet, ma'am.
Is it visible?
Yes.
Now it's visible. You need to go full screen.
Yes, ma'am. Yes, ma'am.
Yeah. So I think some of the parts of the conservative have already been covered, a bit touched by the previous speakers.
Ma'am, could you please put it on screen, slideshow mode?
Slideshow.
It is already a slideshow from my side.
Here you
You'll
can
need to
do
stop
it again.
sharing and reshare again, ma'am.
No, full screen.
It is not a slide share.
It is showing
It's
as
showing
resume slideshow. Can you share it again? Then it will come. Yes.
It's okay now?
No, madam.
Ma'am, maybe it will take time.
From my side, it is coming okay.
Do it full screen, ma'am.
By sharing it.
Please share again.
Yes, ma'am. Yes. Yes, ma'am.
Yes.
Okay. Yeah. So sorry for these technical glitches. And so the conservative management coming to this, I think some of the parts have already been touched by previous speakers, Dr. Lakshmi, Dr. Ashiri. So various treatment options for the prolapse are the pessaries, pelvic floor muscles, prolapse, or we can say just a maninder, various these laser, radio frequency waves. And just for the pessary, I'm mainly focusing myself on the pessaries. It is a device which is placed in the vagina. Historically, it can be traced back to the Hippocratic era. When very interesting history is there, when in the camels, some pebbles were used to reduce the prolapse. And in women, pomegranate was soaked in wine and put into the vagina. And this is a historical part of the oldest pessaries being used. And the pessaries can be classified mainly in three categories: support pessaries, space occupying, gel horn. The gel horn is a combination of these two. The support pessaries are mainly the pessaries, they're circular shape, and mainly they are fixed in such a way that one portion is near the posterior fornix and anterior part is above the pubic bone, so as to support and takes the uterus directly above. And these are mainly ring type of pessary. And space occupying are just filling the vagina so that relatively the prolapse of uterus is not outside the hymen. And gel horn is a combination of this. So these are the ring pessaries, or you can say previous one support pessaries. And this heavy one are the pessaries which are space occupying, and this is a combination too. Means upper part is a ring shape and lower some heavy, and this is a balloon type of pastries are there, which are usually, these are not being used nowadays. And nowadays we are using, these are pastries which are being in position. How this seems, it is a donut type of pastry. You can see very well, this is the uterus, and below this pastry, it is being lifted upwards. These are the ring pastries, and this is a gel horn pastry. And this is again simple, the pastry which are using nowadays commonly, this is in position. So most pastries are being ring shaped, and they are made of silicone, which are using nowadays. Previously, we are using these rubber pastries, but silicone is much better, and chances of this sterilization, that everything is better, infection is much lesser with this silicone type of the pastries. So, but in which case we use the conservative mean treatment, or we can say the pastry, it is a temporary treatment for the symptoms when the patient waiting for the surgery, or patient is pregnant, or patient is having some decubitus ulcer, or can be a permanent for in the patient in which she refusing the surgery, she is very debilitating, or she is not fit for the surgery. So in these patients, we can go for the pastry treatment. The advantages of pastries are that they are minimally invasive. Is it clear? And what is most of the patients come to us, whenever surgery is advised, every patient will say first, Madam, is there some option that I can prevent it from surgery? So it is minimal invasive, immediate relief of symptoms, and cost effective. This ring pastry very, very cheap. In 50-60 rupees, you get this silicone ring pastry, and improves the system. Symptoms, if minor cystocele is also there, that is also the bladder symptoms are also relieved, and the cystocele to some degree can be relieved by the pastry. Sexual behavior is improved. And once the prolapse is not there, there is an improved perception of the body image by the patient. So which are the prerequisites? If we think that these are, in which patient we can use the pastry? The vaginal mucosa should be healthy, means she should not be having any infections. And the prolapse, if very long-standing prolapse, very massive prolapse is there. Sometimes we see the cases, the prolapse is coming out the middle of the thighs, unattended, means neglected type of prolapse, or procedentia also. In those cases, these pastries may not be so effective. Then see the genital hiatus. The genital hiatus should not be too wide. It should not be too wide, and it should be just, you can say, 4 centimeters or less than that, so as to fit the pelvis, these pastries very well. And the vaginal length, it should be adequate. If some previous surgery has been done, or some the vaginal length, if cystoscopy already been done, and vaginal length is short, less than 6 centimeters, then also the pastries may not be very effective, because if length is less, the upper portion of the pastry might not reach behind the pubic symphysis. And then some strength of the pelvic floor should be there, so as to retain the pelvis, this pastry in the place. And for this successful fitting and continuous use, it is very, very important the counseling of the patient and education. If patient is little counseled about that, and she ready to accept, then the effectivity of the pastry will be better. So in which case the pastry can be unsuccessful? Short vagina, less than 6 centimeters, wide introitus, more than 4 centimeters, perineal body is too small, deficient. If big rectocele is there, previous vaginal surgery with co-stress incontinence, these may be little less effective, or we may say that in some cases we should not put the pastry in these candidates. Now, very, very important, how to insert the pelvis. This, I'm talking of this ring pastry, which is commonly used. Now, this is the first diagram. You have to fold the pastry. The ring pastry is being folded. After this is inserted in the vagina, first towards the sacrum, then it is opened inside and unfolded and brought behind the pubic symphysis. First step, second, and third step. And then after this, you have to put one finger in between the vagina and the pastry to see that the finger can be well inserted, to see the tight fitting, or it shouldn't be too tight or too light. So once you, very, very important, once you inserted the pelvis, ask the patient, don't send the patient immediately home. Ask her to just stay there for half an hour to 1 hour. She can ambulate, she has to cough, she can pass urine.
And only after that, because we have to see whether the pelvis is fitted rightly or not. If she's not able to pass urine, it means it is too tight for her. We may have to use a smaller size of the pelvis. Or if she's coughing and it comes out, it means the size is not proper, and we have to use a little larger size of the pelvis. It is available in 5 to 6 sizes in centimeter, 4 centimeters, 6 centimeters, and 8 and 10 centimeters. So then very, very important, once patient has been able to move, then instruction should be given when to follow, how to clean the pelvis to avoid the complications associated with this. So how to determine the size of the pelvis? It is very important. You put your 2 fingers in the posterior fornix and depress to reach the lower edge of pubic symphysis. Just like we say in the pelvic assessment, we do the diagonal conjugate. So put 2 finger posterior fornix, depress, reach the pubic symphysis, measure it, and -1 centimeter is usually the commonly used size of the pelvis. The size of the pelvis, pessary, which is used in pessary, which is used for this. Then comes how to follow the patients of this pessary. These women should remove the pessary once in a month, usually after menstruation, wash it with water and soap. And first follow-up should be usually after 2 to 4 weeks to see whether she is satisfied and there is no problem, no discharge is there. And women who cannot take self-care are to be followed every 2 monthly, so that instead of changing every month, we can change 2 months in that patient who is not able to change herself. If no complications are there, patient is well educated, can change the pessary herself, then she can come for the visits after every 6 months to 1 year. The various side effects of these pessaries can be, the common side, she can have foul smelling discharge. Excuse me, is there some timer is there?
Yes, ma'am. Yes, ma'am. 3
You
minutes
have
left.
4 minutes. 4 plus 2. 6.
Yeah, okay.
Well, 4 plus 2, 6.
Common side effects are the vaginal discharge, bleeding, pain, or vaginal erosions, and also constipation if it is not properly fitted, and difficulty in urination. So these vaginal erosions are the most common complication along with the vaginal discharge. So these two are the common complications with this pessary, but they both are treated, or we can say if their proper care is taken, then the problem is not there with them. So then comes to forgotten, neglected pelvis. If patient is not able to follow up, she doesn't come to you. She comes to you after 1 year and she hasn't changed the pelvis. She has not removed the pelvis. So there can be the various fistula formation, or pessary can get incarcerated, or later, very, very few cases, there can be hydronephrosis urosepsis. So this is one case where the pelvis, this pessary got incarcerated. The vaginal epithelium got overgrew over the ring pessary. It has to be cut open to remove the pessary. And these are the cases of forgotten pessaries. So if we compare what is the success rate of surgery or pessary, it has been seen that almost similar results are there for both at 1 year of the follow-up, 70 to 90% relief in the symptoms. Then if we, this is one again latest study in 2018, where the treatment of pelvis pessary versus surgery was compared, and it was seen that pessary avoided surgery in 72% of women, although in these women, the symptoms were less. So the pessary cannot be used in the major degree, means procedentia, that in minor degree of prolapse, it is very, very effective to use the pelvis. And by this Canadian Society, the pessary should be considered in all women presenting with symptomatic prolapse and or urinary incontinence in minor degree of this prolapse. This Cochrane database says that there is urgent need to do some more randomized study just to say whether the pessaries are better surgery or conservative treatment. And when conservative treatment like physiotherapy, surgery have either failed and not suitable, then the pessaries can be used. So now a latest one line about this, the self-inserted pessaries are available, which patient can introduce herself, though they're very costly and they have to be removed after 1 week. This is a simple diagram. You just pull this inserter, it will go inside, and for removing this thread is to be pulled out and it will come out. So training is to be given to the patient for the self-inserted pessaries. The second conservative treatment is the Kegel exercises. I think my previous speaker had discussed about these Kegel exercises. Very, very important to teach the patient, though Dr. Maninder has also commented that we can use so many things for these exercises. But this very simple is we have to ask the patient to squeeze the perineal muscle as if she has to stop the urination in the midstream. This is very, very important to tell, because sometimes you ask the patient to squeeze the muscle. Instead of squeezing the muscle, she keep on contracting her abdominal muscles, keeping those inside. So best method to tell, she has to stop the urination as if she stops the urination in the mid-time. And this is for 5 to 10 seconds. She has to contract, release for same time, and at least 10 times, 3 times a day. She can do it in any posture, sitting posture, lying down, or standing as well. And then indication of pelvic floor in minor degree prolapse, first or second degree prolapse, it is used, or prolapse during pregnancy, or patient with stress incontinence can be used. The patient having prolapse without symptom, as Dr. Suman has very well said now, that the patient should be asked or she should be examined. If minor degree of prolapse is there, she's not having symptoms. So this is very, very important. Dr. Suman has commented the prolapse without symptoms. We should ask her to go for the pelvic exercises so that it can be avoided. Prolapse can be avoided. And second, very, very important, these are the Kegel exercises. You have to lie down, keep it up, and then repeat it for 10 to 20 seconds. Advantages are there. Again, minimal risk. It prevents worsening of symptoms, reduces the severity of symptoms, and delays the surgical treatment. Another latest thing is the laser treatment. The prolapse, it is new. The main advantages are there. This is the instrument which can use. The main thing which it causes the fibrosis or shrinkage of the vaginal canal, little bit, and the cystocele for minor degree of prolapse, the anterior vaginal wall cystocele, it is very, very good. No anesthesia is required, no recovery time, no incision, no suture, but it is costly, and still more and more data is required to say or to compare it with the other.
Madam, sorry to interrupt you, your time is up.
Can I take 1 minute?
Yeah, yes.
Just to conclude, in modern era, past still have some role, especially in the patient who are waiting for the surgery. Successful plasticity is depending on the patient satisfaction. Regular follow-up is to be done. The perineal floor muscle training is also a very, very good option for the patients. Thank you.
Thank you, ma'am.
Pratik, can you comment? Pratik.
I think that was a very exhaustive lecture, and in a very short space of time, she gave us so many key insights, properly like a medical college professor. Systematically, she went about it. That's what I liked. It was very well structured. And that's the benefit of having such eminent and senior teachers from all parts of the country in this course. Thank you, Dr. Sumant Sinha, for bringing such wonderful faculty to this course. And for all of us, I think it's been a very enlightening discussion so far. Thank you very much, Dr. Savita Singhal, for being with us. Can we move to the next speaker, please?
Thank you, Dr. Pratik. Thank you, Dr. Doshi, Dr. Suman.
Thank you, Dr. Savita. Neha Malhotra, who speaks next, is otherwise engaged and she'll be joining us shortly. And Dr. is have medical issues. So I request Tambe to introduce the next speaker, Dr. Sameer Pradhan.
So it's my proud privilege to introduce Dr. Sameer Pradhan, and he's a fantastic, eminent vaginal surgeon. He's very well known in Mumbai from where he hails. In fact, we are both from the same institution, KM Hospital, Mumbai. A long time ago, about 25, 30 years back, I was his intern and he is my senior. He is very well known in the field of vaginal surgery and urogynecology, also laparoscopy. He is somebody who is invited to multiple conferences and workshops to demonstrate surgery, and he is also the joint secretary of the Society of Vaginal Surgeons of India, the Maharashtra chapter. Sir is going to be speaking to us regarding his pet topic, but he will have to restrict himself to 15 minutes. Can somebody please unmute him, and let's hear from Dr. Sameer Pradhan, sir.
Thank you, Pratik, for the kind words of introduction, and thank you, ICOG team, for this privilege to present my talk. And thank you, Vidya Thobi madam. Madam had attended my talk in that searchlight, and then she told me to present it again over here. Stop. I open my screen 1 sec. I think I had opened it, but it is not seen. I'll just try to
Yes, sir. Take your time. Be comfortable.
Yeah, I thought it would be seen on the desktop, but it is not seen.
Dr. Vidya Thobi, in the meantime, are your technical issues sorted? I hope we'll be hearing from you soon.
I will have to leave and rejoin because I had opened this talk, but I don't know what happened. I'll just.
All right, sir. In the meantime, if any of the previous speakers wants to take the questions that are there in the chat box until Dr. Sami rejoins, you can have those.
Dr. Nina, sir.
Has she joined, Dr. Nina?
Yeah, she just messaged that she's joined, but somebody will need to make her co-host. And the ICOG team, technical team, make her
team.
So she can start. Dr. Nina will start, and then Dr. Pratik, once more, you have to introduce.
I'm happy to introduce Dr. Nina. Dr. Nina Malhotra is well known to all of us. She's from AIIMS, New Delhi.
Samir could share his, I think.
I think Samir can share. Okay.
Okay.
1 second, sir. Me.
Dr. Nina has also joined. Dr. Vidya Thobi, madam, has also joined.
Dr. Nina
Poonam, whoever is in the backend team.
Difficult to join. I'll speak to the ICOG team. I think we'll wait for Dr. Samir, sir.
Okay.
Okay.
Yeah,
Yes.
Lisa. Dr. Samir, we can't hear you, sir. I think you need to be unmuted. I've sent you an unmute request.
Yeah. So should I share now or should I wait?
Yes, please. Please go ahead. We're waiting for you.
Please start, sir. Please start.
Okay. I just shared my screen. I don't know what happened again. 1 sec. I was told to not share, but now it is not coming again. What happened? I don't know. Yeah, now it is coming.
Yeah, it's coming. We can see.
You can see?
Yes, sir. We can see.
Full screen.
Can see, sir.
Okay. Yeah. So the talk is surgical management of prolapse in the reproductive age group. And the aim in this reproductive age group is to mainly relieve the symptoms, restore the anatomy to normal, restore the functions to normal, prevent recurrence in the future, maintain the childbearing potential, and maintain the menstrual function. However, there are certain challenges. The repair of prolapse should not hamper fertility. It should not hamper the course of normal delivery. And the repair should not give way after childbirth and cause a recurrence. Hence, the abdominal sling operations were devised by mainly the Indian surgeons to overcome all these challenges. These are the mainly Purandara cervicopexy, Shirodkar sling, and the modifications. And the vaginal surgeries where the Fothergill's repair was a traditional repair, which was modified by Shirodkar's uterosacral advancement. And nowadays, there is this sacrospinal hysteroplexy. The Ani stitch, I think Vidya Thobi madam will be talking about it. So it is done only, it's an intraoral tightening. I have done it only for pelvic organ prolapse in pregnancy in the first trimester where it causes retention of urine. So I'll be not talking about this surgery. The principles are, we all know since yesterday and today about a Delancey's support. So the abdominal surgeries restore the level 1 support, that is the uterosacral cardinal ligament complex by a suspensory mechanism. And the colporaphies, which can be done alternately with the Fothergills, are used to reinforce the level 2 support. The first such surgery, which is easiest, is the Purandare cervicopexy, described originally by Dr. B.N. Purandare in 1965. Initially, he used the rectus sheath strips and they were anchored to the anterior part of the isthmus through the 2 leaves of broad ligament. Later on, this rectus sheath was replaced by polyester. This is a dynamic sling, means whenever the intra-abdominal pressure increases during coughing, This sling braces the cervix towards the anterior abdominal wall. But however, it is an anterior sling, so the disadvantage is the UV fold gets obliterated and there is an increased risk of enterocele. Dr. Praveen Matre and Dr. V.N. Purandare modified this sling. They used the Mercilin tape. It was viewed in the rectus sheath and the tape was anchored posteriorly through a window in the broad ligament. Dr. Prashant Mangeshikar performed this surgery laparoscopically, and my teacher, Dr. Amar Bide, used a vaginolaparoscopic approach. I'll try to show a video of this, very small video. Initially here the vaginal dissection is done in the vesicocervical space till the level of isthmus, as one does in a modified Shirodkur's cerclage. Anteperitoneum is not open. The Mercilin tape or the polyester tape nowadays, it is true bond, is fixed by driving it through the cervical tissue. An additional stitch can be taken to anchor this. Then one puts a laparoscope and then one sees the exit of the round ligament. And from there, one can use a long artery like a Berkeley-Bonney artery and drive it. One has to incise the skin up to the level of the rectus muscle, and then one can drive the long artery, and the artery comes out near the isthmus, and then one has to pierce it and take the Mercilin tape upwards. The same thing is done on the right side and the left side, and then this particular Mercilin tape is fixed to the rectus sheath. So one need not open the whole phalangeal incision, only laterally it is done under laparoscopic guidance. This was done by Dr. Amar Bhide sir, and we have done quite a few cases. Here we can see the tape from one round ligament to the other, and the uterus becomes an abdominal organ. So these are the basic steps, and sometimes one can also do a round ligament plication with this. Shirodkur's sling was described way back in 1958, and it is the most anatomical repair. Dr. V.N. Shirodkar initially used fascia lata strips and anchored it to the posterior part of the isthmus and then to the sacral promontory. Later on, this fascia lata was replaced by the polyester tape. It is the most correct sling anatomically. Only in cases, and can also be used in the cases of poor muscle tone or a defective rectus sheath or failed cervicopexy. Briefly going through the steps, the incision required is midline. The bowels have to be packed away using a Barfol self-retaining retractor. One cuts the peritoneum over the sacral promontory, more to the inferior and the right side. Superiorly, there is the left common iliac vein, and one has to be careful. One exposes the anterior auditory ligament, fix the tape at the level of insertion of uterosacrals. Shirodkar had used those Shirodkar's needle, but one can use a long artery and go retroperitoneally, or if one opens the peritoneum, one can again resuture it. The stay sutures are taken on the anterior auditory ligament, safeguarding the left common iliac vein, the sympathetic plexus, the middle sacral artery, and the emissary veins. Then the Shirodkar's tape is needle is passed from the right side, or a long hemostat is passed retroperitoneally, medial to the right ureter till one reaches the uterosacral ligament and retrieves the tape on the right side. On the left side, one uses another tape and takes a psoas major muscle loop. This is to prevent the obstruction of the sigmoid by the tape, because the sigmoid is on the left side. One also has to make this loop quite away from the genitofemoral nerve, and one has to be careful of the left external iliac vein while making this loop. Then this tape is passed through this loop, and then one goes in the retrorectal space, which is the holy plane below the sigmoid colon, and the tape is retrieved up to the anterior ligament. Then the tape is fixed to the anterior ligament with permanent sutures. The traction should be enough to make the uterus an abdominal organ, but one has to allow 4-finger breadth space in the false pelvis for the sigmoid colon to distend. And one then sutures the peritoneum over the anterior ligament. Abdomen is closed in layers after confirming the hemostasis. This was a very difficult surgery, and one had to be an expert or have to do the surgery under supervision or under proctorship. Luckily, Dr. Amar Bhide and recently Dr. Sarogi sir assisted me in this surgery. So then Dr. Khanna modified this. Instead of going to the anterior superior longitudinal ligament, he fixed the tape to the anterior superior iliac spine, which is a bony support. Dr. Rustum Sonawala did this surgery only on the right side to avoid the sigmoid colon and the left side, and fixed the tape to the anterior longitudinal ligament at the level of S1 vertebra. More recently, Dr. Neeta Varti and Dr. Pandit Paraskar, the Indian surgeons, are doing this surgery laparoscopically. It is more easier laparoscopically. It is less invasive, less chance of post-op ileus, faster recovery, magnification is there, and easy access in depth. However, there are certain limitations of all these sling operations. The selection criteria: the uterocervical length has to be less than 5 inches, and there should not be any associated cystocele or rectocele. Weak ligaments used to cause recurrence, which is now overcome by the polyester tape, which is a type 3 mesh. Posterior slings used to cause retroversion, so one has to do a round ligament plication. And the anterior slings cause a de novo enterocele, for which one should do a Moshkovitz or a Halban's repair. Recently, laparoscopically or by open technique, one is can do a sacral hystropexy. It was first described by Swain, and Constantini had done a randomized controlled trial wherein the monofilament polypropylene but macroporous mesh was used. This is not like the hernia mesh. The pores are bigger in size so that the fibroblasts can grow through the pores. It overcomes existing facial weakness, and attachment is to suitable fixation points in the pelvis. It overcomes the effects of facial detachment from the original structures, reduces recurrence, and the risk of mesh erosion is more with the colpopexy than for wall prolapse, but almost very negligible with a hystropexy. Only precaution is while dissection, one should leave the fascia on the vagina. The steps are similar to the Sidotkar's sling. One has to expose the anterior longitudinal ligament, use a soft macroporous polypropylene mesh, cut it in a Y-shaped manner. UV fold is dissected up to the level of isthmus, and one limb is fixed posteriorly to the level of uterosacral. Earlier, people used to go up to the level of levator ani, but that has caused pain to the patient's post-op. And it also can, that dissection can interfere with the hypogastric nerve fibers and cause a lot of bowel symptoms later on. So nowadays it is fixed to the level of uterosacrals. The other limb is brought to the avascular space in the broad ligament and fixed anteriorly to the level of isthmus, and the proper traction is given, and the stem of the Y is fixed to the anterior longitudinal ligament. The excess mesh is cut, and all this mesh have to be peritonized. Advantages: it is a strong repair, bony point fixation, fibroblasts grow as I had said. So the deficient collagen part is taken care of. Vaginal length is not compromised unless any vaginal repair. So it does not interfere with the patient's sexual life, and the uterine axis is unaltered. However, complications are hemorrhage, bowel ureter injury. Earlier they used to fix the tape with tackers, but then tackers sometimes can cause osteitis, bone infection, which is very difficult. And patient has a pelvic symptom like a prolapse intervertebral disc. Mesh infection is there with all mesh, exposure, and extrusion. And if the hypogastric nerve fibers are damaged, then there can be altered bowel and bladder function. Dr. Virkud has done a combination of the Purandaris pexy on the left-hand side and a Shirokar sling on the right-hand side. So he calls this an open sling with a dynamic as well as static support. Only thing is the uterus undergoes a dextrorotation, so the left side uterosacral ligament is plicated. It is easy to perform, double support, bony as well as dynamic. Tape is posterior, hence no risk during LSCS, no risk of enterocele, and no risk of sigmoid colon. Dr. Vivek Joshi had a lot of series of open burst, and he then also modified this to fix the tape to the iliopectineal ligament of Cooper, which is a reflected part of the inguinal ligament. And Dr. Noy Gunther from Germany did this same surgery laparoscopically, initially for wall prolapse, but now it also does hystoscopically pectopexy. He uses something called PVDF mesh, which can be left without peritonization and does not cause adhesions. The dissection of Cooper's ligament is done till the level of corona mortis, which is a connection between the external iliac vein and the obturator vein. And anchoring is to the level of S2 vertebra, so that the one gets the proper physiological axis of the upper vagina. The advantage of histopectopexy is that hypogastric nerve involvement is not there, so constipation and other bowel symptoms are not there. And even it is less risky because there is less risk of ureter injuries or bowel injuries. I'll just skip the A repair and paravaginal defects. Coming to the vaginal surgeries, Manchester in Manchester town, first Ian Donald and then his student Fothergills first described this repair. It is done when there is elongated cervix. In nulliparous prolapse, sometimes when the ligaments are strong, the uterosacrals, just the cervix elongates and the fornices are deep. So there is intravaginal elongation. The steps include done in lithotomy position. Dilatation is done till number 10 Hagar so that one can place the Sturm-Dorf sutures. Curettage is done. One has to rule out any problems of the cervix and the endometrium. Cervix is pulled down and a circular incision is taken. Anterior and posterior flaps are raised. Fothergill's points, the anterior point is below the urethral meatus. Posterior is the apex of the pouch of Douglas, and two lateral points as per the elongation. Fothergills used the cardinal McEnroe's ligament. It was clamped, cut, and transfixed and mobilized, and then it was the sutures ends were kept long. The descending cervical artery on each side was ligated, that is optional step. Then the cervix was amputated. Posterior Sturm-Dorf suture was taken and the end was kept long. Then the anterior colporrhaphy was done by Dr. Schanbach's technique, wherein the anterior vaginal mucosa is not excised. The cardinal ligaments were advanced over the anterior lip of cervix and fixed with the vicarial sutures. Then the anterior Sturm-Dorf suture was taken and covered, tied, and then the lateral sutures were taken to cover the raw area. At the end of this, the posterior colpoperineuraphy was done. The limitations are that this cervical amputation can cause habitual second trimester abortions, preterm deliveries, pre-labor rupture of membranes, fibrosis, stenosis, cervical dystocia, secondary infertility, and hence it is not to be used in patients who desire childbearing, and it cannot correct complete eversion of vagina. Dr. Shirodkar modified this surgery and he found that the uterosacral ligament is a more stronger ligament, and he did not do the cervical amputation. The P-pouch was open, unlike in Fothergill, and the uterosacral ligament is used instead of cardinal ligaments, more physiological, and the ligaments get shortened and avoid cervical incompetence. Can I have 1 minute, please?
Yes, sir, yes.
Yeah, so I did one surgery in 2007 where there was a nulliparous prolapse. Patient was recently married. UCL was 4.5 inches. And I realized that with a Purandares, the cervix is going to be long. So we raised the vaginal flaps, P-pouch was open, uterosacral ligaments were clamped, cut, transfixed. Descending cervical arteries were ligated. Our partial amputation was done. The muslin tape was fixed to the anterior lip. Then we did lap-assisted PEXI as I had shown in the video. Then we did Shirodkar's uterosacral advancement. Then we tied the posterior Sturm-Dorf and anterior Sturm-Dorf, and then pulled the tape and tied it to the rectus sheath. After suture removal, the patient did not follow up. These are the actual notes. However, in 2023, one of my friends managed to see this patient. She was pregnant. He had difficulty doing a Shirodkar stitch. And then he put a Shirodkar circlage, but because I had done a slightly more amputation and I was too junior that time. So I had forgotten that the cervix shrinks after Fothergills. But luckily, this patient had an uneventful delivery. And then same thing was described by Dr. Korean Joseph in 2023 AAGL. And I had an opportunity to do this similar surgery again once on 11 September this month. This was the case, 3rd degree prolapse, cervical erosion, mild cystocele, enterocele, high rectocele present. UCL was 4 inches. Patient did not want childbearing. She had completed her family, but she was 35 and she wanted to retain the uterus. So I amputated 3 inches of the cervix and then did the modification of the Fothergills with the site-specific, with the laparoscopic assisted PEXI. This is the final view. I also did bilateral salpingectomy on her. And this another surgery which was not described much, only luckily I have seen Dr. Saroghi sir doing it. It's Nadkarni sleeve excision done by Dr. Nadkarni from I think Baroda. It used to remove only the central cylindrical part of the cervix, and the internal os and the external os are saved. Only thing is one has to dissect the whole descending cervical artery, because that has to give and it has to be the sheath, adventitial sheath has to be saved, so that the cervix which is left is not necrosed. I do a lot of sacrospinous colpopexy for wall prolapse. Dr. Saroghi sir has taught almost everybody in Cooper and to us during his AFG workshops about this surgery. But there has been, since mesh is banned in the United Kingdom, they do sacrospinous hysteroplexy. I have never done it, but then they do it in the sacrospinous colpopexy or hysteroplexy. One does a high posterior colpotomy. Right rectal pillar has to be perforated so that one enters from the rectovaginal space to the right pararectal space. The right sacrospinous ligament is to be exposed. One has to require 3 retractors, a narrow devers, Navratil retractor retracting the bladder medially. One has to be 3 centimeters medial to the ischial spine. 2 number 0 PDAs or a proline or Weichel sutures have to be taken in the sacrospinous ligament. 2 fingers medial to avoid the internal pudendal artery and the pudendal nerve. And only one has to go to the substance of the sacrospinous ligament. And then it is attached to the uterus where the uterosacral ligaments are attached. A repair, P repair can be done, and the sutures are tied when half the posterior colpography is been done. So conclusion, pelvic organ prolapse in reproductive age group in nulliparous woman or multiparous woman desiring further childbearing, or those who have completed childbearing but require menstrual function, comprise 6.5 to 10% of all pelvic organ prolapse. And one can combine 2 surgeries as I had shown earlier, but adequate counseling to be done. That always a need of second surgery around 10 to 15 years. Thank you very much for the patient hearing. I thank Dr. Amarnath Bide sir and Dr. Rajendra Saroghi sir who has taught me all this.
Thank you, Dr. Sameer Pradhan, for a wonderful talk. I think that was very instructive for all of us. You went through all the surgeries in a very short space of time. For reasons of paucity of time, obviously you could not show the videos, but we look forward to seeing you again on the ICOG platform, maybe where we can have your skills exhibited in a better fashion.
Thank
you.
you.
Dr. Saroghi sir is the
Pratik,
legendary
I can
teacher
just
of
ask
teachers.
one question, Pratik.
Yes, ma'am. We are running behind schedule.
I think,
Maybe
Sameer, you
can
have
type
covered
it in the chat
it all
box.
so historically. You have taken A to Z of everything. But somebody who is starting into PG students, how you are going to advise them? What should they start doing it?
So when I was a second poster in Dr. Vinita Salvi unit, on one day we had 2 surgeries. One was a Purandara cervicopexy and one was a Shirodkar sling. And I assisted the lecturer, the Purandara cervicopexy, and then madam with the lecturer did the Shirodkar sling. She categorically told me, when you start private practice, first do only Purandara spexy. It is easier, much easier surgery. The patient will get those relief of symptoms till she wants a pregnancy. If you want to do Shirodkar's sling, you have to have a preceptor who has done this surgery. Open Shirodkar's is more difficult because you have to really do it in a depth. So if the patient is obese, it's very difficult to access. Laparoscopy is much easier because with a laparoscope you can go near. But then for that you have to learn endosuturing first. So this laparoscopic assisted Purandara spexy everybody can do, because everybody can do dissection for A repair. So one has to do dissection for A repair, fix the tape there, then put a laparoscope in the through a everybody that has done a tubal ligation. So you put a laparoscope to the 10 mm port. Then buy a long artery. Earlier there used to be Gilliam's ventro suspension operation where the round ligament plication was supposed to reduce prolapse, which is actually a wrong technique. But that forceps was there, Berkeley-Bonnie's forceps it is called. You see the exit of the round ligaments by the laparoscope. There, like a mini laparotomy, just keep on cutting skin, subcute, and the sheath, and then see the rectus lateral border. And then you can railroad that long artery through the 2 leaves of broad ligament. And when you reach the antiphonics, you will just fill it and then you just dab it, retrieve the tape, and then you fix the tape to the rectus sheath. So this is a minimal invasive surgery which can be done by anybody. Like I have done such in my private practice.
Thank you,
Sameer. I
Dr.
think
Sameer. We are running late by
short,
about half
running
an hour.
short
I
of
think we
time.
should move on. Dr. Maninder, please address any questions in the chat box, please. Can we move to the next speaker, please? Thank you, Dr. Suman Sinha, for this opportunity. I hand over back to Dr. Janmajay to take us forward.
Dr. Janmajay.
Okay. Whom do I introduce? Dr. Nina or Dr. Thobi, Vidya Thobi?
Dr. Nina, sir. Good, Dr. Nina, sir.
Okay. Good evening, everyone. Good evening, everyone. Respected FOGSI office bearers, Dr. Jaideep, Dr. Madhuri and all, and ICOG office bearers, and conveners, coordinators, particularly Dr. Suman and Dr. Kavita, for inviting me to this souvenir. I am privileged to introduce our speaker, Dr. Nina Malhotra, who is now the professor and head Department of OBG, All India Institute of Medical Science, New Delhi, and head of WHO Collaborative Center for Research in Human Reproduction, and also President-elect Indian Fertility Society 2024 to 26. Madam is Senior Vice President IFS 2022 to 24. She is a Commonwealth Fellow, Vice Sakat Fellow, and done ICMR DHR International Fellowship for Fertility Preservation in France 2023. She has received so many awards: Sir Malcolm Black Fellowship 2015 from ICOG in ICOG London, Overseas Fund 2010-2019 ICOG London, Imaging Science Award FOGSI 2006, CS Dawn Award FOGSI 2009, 10 and 11, Korean Research Award FOGSI 2010. Her research interest is on endometriosis, fertility preservation, and ovarian tissue cryopreservation. She has funded projects on ICMR task force on GTP, on PCOS, ovarian tissue cryopreservation, stem cells in atrophic endometrium. She has so many publications, over 135 papers in peer-reviewed journal. Now she will speak on ultrasound and pelvic organ prolapse. Over to you, Madam Nina, Madam.
Good afternoon, good evening, everybody. Thank you, sir. Thank you, Janmajay, sir, for introducing me. I don't think I will take a lot of time. Thank you, the organizing team, for this ICOG, for having me to deliberate on an interesting subject. And I would just share my slides. Thank you, Dr. Suman. Thank you, Dr. Niharika, and the team of the ICOG. I've shared my screen. I think I can share my screen, Niharika. I am
yes,
on. Can
you can.
I can?
So should I share, ma'am? Should I?
So
you want to share?
No, I can share my slides. I have got the laptop connection, so I think that'll be better if I can go through my own end.
Yes, ma'am. Yes.
Yeah.
Yes, ma'am.
So am I allowed sharing? Yeah. So can you see my screen now?
Yes, ma'am. Please.
Yes,
Yes, ma'am.
Thank you for giving me this topic.
I'll
make a full screen. Can you see it now?
Yes.
This is your
Yes, sir. Yes, ma'am.
So thank you. I would have taken a little liberty for changing the topic from role of ultrasound to role of imaging in pelvic organ prolapse. And to be honest, there's a disclaimer. I have not done many imagings in pelvic organ prolapse. But I thank, because of this lecture, I could read and understand, and I got new understanding that yes, there is a place of imaging. Having said that, I don't think in the second day of this 3-day series, I need to tell people what pelvic organ prolapse is, because there have been lectures yesterday that I could see in the program on defining POP or pelvic organ prolapse with descent of one or more, the anterior wall or posterior vaginal wall, the uterus, cervix, or the vaginal cuff, or the vault, which is post-hysterectomy. When we know that the lifetime risk of surgery in a POP is close to 20%. Now, again, the POPQ classification, which is the ICS recommendation of using this as quantification system, because this POPQ helps in understanding the exact compartment that is involved and, of course, the extent. So I will not deliberate and I will come straight. to understand, is there a place? And if there is a role, why do we need to do imaging and what sort of imaging we do? So obviously, we are doing imaging with the intent to see beyond the surface anatomy. And I also wondered, everything is hanging out there. You're seeing the prolapse to any degree. Why should you really need imaging? But then there are reasons, and I will share you, because there are drawbacks in the POPQ. When we classify the patient on a POPQ for a prolapse, we are not identifying the underlying supporting defects, which we actually need to understand. This system doesn't allow us to differentiate the organs that are involved, particularly in a posterior defect, which may be easy in our clinical examination, but not so in some difficult and challenging cases, particularly between a rectocele and an enterocele. And of course, if you look at imaging, it helps to diagnose conditions which are mimicking like prolapse, like maybe a urethral diverticulum and very uncommonly an anterior vaginal wall fibroid, which can. So what is the imaging that you can do? Is we have ultrasounds by routes like translabial or transperineal, fluoroscopy, which could include a proctography or a difficography, and MRI. So I'll move on to the first, which is ultrasound, which is easy, cheap, and of course, all gynecologists are so conversant that they almost can do this modality of imaging on their own because it's easily available to most of us. So if we look at it, what are the situations where we would really demand or where we should fall back to do? I'm sure you remember from your MD or your MBBS days, prostadentia. And I think prostadentia is something where if we see a prostadentia and diagnose it, it's pertinent that we put in a transabdominal probe and look at the kidneys, because there can be a long-standing prostadentia in a woman who has, or a neglected incarcerated prolapse, where you get the picture on an ultrasound suggestive of hydroureteral nephrosis, which can be occurring in up to 3.6 to 30% of cases. And the reason is very obvious, because when there's a massive prostadentia, it's dragging the ureter along. There'll be uterine kinking, and of course, when there is a backpiling effect, it will be leading to hydronephrosis and a kidney injury. And also, if you know that there's a hydroureteral nephrosis, it forewarns a surgeon. How good or bad you're a surgeon, the chance of a ureteric injury are always higher in a prostadentia as compared to a prolapse, which is simple. So therefore, you have to take this in account and always palpate the ureters, particularly when they are more dilated. Having said that, let's look at the other kind of ultrasound that we do in women who are not having prostadentia, i.e. prolapses of varying degree. And that is doing an ultrasound by a route which is called as a translabial ultrasound. Now, what is the translabial ultrasound? It's simply a transabdominal probe that you have anything between 3.5 to 5 megahertz convex array transducer. And what you do is you can do it in the patient in a Fowler position or with the hips bent and abducted, or even in a standing position. But the catch is this time you're doing it with an empty bladder. And what you do is you put the transducer over the labia, over the perineum, after parting the labia to obtain a mid-sagittal view. Now, the entire, transducer in this case should be covered with a jelly, because if there are air bubbles, they will cause artifacts. And also, if there are plastics or condoms which are covering, can be used to avoid that. As we're doing it in a transvaginal, we use condom or a cover. We can use this to avoid that air bubble formation. So this is a mannequin picture, as you can see in A, which is showing how a covered transducer is placed over the perineum, and this is the way you look at the anatomy. If you can see it on the transducer, you see the diagram which is showing the urethra, the bladder, and a prolapsing, a vagina with the uterus. That's the position that you see. So the reference point in this image, if you see here, is a two-dimensional plane where you look at a mid-sagittal plane of the pelvic floor. The main structures identified on this plane, if you see from the right to left, you can see is the pubic symphysis, which is marked as SP. And you see that U is the urethra, the V being the vagina, the UB being the vaginal bladder. And what you see is the prolapse, which is marked here, the puborectalis muscle and the rectum. And therefore, with this is a normal view as you see if you do a transperineal or a translabial ultrasound. Now, having this technique, you have to do the assessment of a prolapse by using a translabial. I will show you some images how to see it. You produce these images by performing in a woman who is lying in rest and a maximum Valsalva. Use the horizontal plane through the posterior inferior margin as a reference, using pubic symphysis as a reference point. And here, if you see the most dependent portion, that will be the bladder, which will actually tell you the presence of a cystocele. And you're wondering why? Because you can actually quantify. The leading edge of the cervix can define the prolapse. And of course, descent to the rectal ampulla is the one which defines the posterior compartment of the prolapse, i.e. the rectocele. Now here lies the catch. How does it help? An enterocele can be defined much better because also, not just that you distinguish an enterocoel in the posterior compartment, you can also identify whether it's an omentum which is coming down a small bowel or just a fluid-filled peritoneum. And these are the images, as you can see, as in the mid-septal, the pubic symphysis being there. You can see in the mid-septal plane of this image, you see the cystocele is marked as C, the U is the uterus here, and R is a rectal ampulla. So very clearly, you can define these in reference to the pubic symphysis as to what are the structures in case you have a doubt. And this is how you see. So this is how you differentiate when you see in this first image as a pubic symphysis being placed there. And there you see that there is the uterus marked in the bladder. There is a rectal ampulla. There is the anal canal being placed here and the vagina. Now, if you were to do in a Valsalva, this is where you will see the rectal ampulla, which is descending below. And this is how you differentiate that this rectal ampulla that is descending is actually the rectocele. In contrast to between a rectal ampulla and the uterus, you see a bulge, which is an enterocele here. And this is how you would use a translabial ultrasound to distinguish between a rectocele and an enterocele, because enterocele can be challenging in some patients. And therefore, this is the place of doing a translabial ultrasound. Now, looking at, is this, just evidence there? Yes, there are publications. Mainly a publication which comes from China, which looked at the use of translabial ultrasound in the diagnosis of pelvic colonic prolapse, in its correlation to say whether how useful it is when you use it for a POPQ classification. And they used 363 patients, and they found that when there was no rectocele or enterocele in most patients, which was not detected by PQ, they were the cases where they could pick this up on an ultrasound. And what was found from this data, looking at the sensitivity and specificity being almost 100% sensitivity, but specificity was not so good. What is important here that the positive predictive value for ultrasound, a translabial ultrasound, while is less, it's the negative predictive value, which is almost 100%, i.e. that if you don't see an enterocele on a transperineal ultrasound, you're 100% sure that there will not be enterocele. While if you look that there is an enterocele, there would be around 2.38% people or women who would actually be diagnosed on a POPQ as having an enterocele, which actually is not present. So that is the way to look at from this paper. Now, then is it of value? Yes, there can be some situations where you can have, pathology other than a prolapse, but it looks and mimics like a prolapse. Like if you can see that there is in the picture A and B, these are images of a patient who was actually thought to be a prolapse, but it was actually anterior vaginal wall leiomyoma, which was mimicking the anterior compartment like a cystocele. And such cases are the where you can miss a diagnosis, or you're not very sure, ultrasound can be handy. Also, in some situations where there's a urethral diverticulum, and therefore in the anterior compartment, when you do an ultrasound using the transperineal or a translabial approach, you can pick it up. And of course, a distinction between an rectal and enterocele comes much more readily when you use a translabial ultrasound. Now, is it just the 2D which is enough for us to diagnose, or is it used, or is there some other, use of a better modality? And that is when you do a 3D, 4D imaging. That means you have a third dimensional ultrasound when you do a translabial. That means the same transducer that has a 3D facility, then you can get better morphological imaging, particularly of the muscles. And what muscles are we really interested in? We're basically interested in the puborectalis, because we know that this is the muscle that will be injured or that will be traumatized during a vaginal birth. And this is the one which is associated to be looked into in a prolapse. So in pelvic organ prolapses, we know that the avulsion injuries are more common at the insertion of the puborectalis muscle on the inferior emi of the pubic. And this is something which you can never be able to identify if you just do. Maybe you can always diagnose a cystocele, maybe you can always be good at diagnosing an enterocele or a rectocele, but this is something which is now being accepted to be picked up best on ultrasound, particularly when you have a 3D, 3D images are created on your machine. So the levator and avulsions are identified in this ultrasound in an axial plane. And what you do is when you create the images on a rendering mode, that means you've taken the images and then you put the machine on a rendering mode, you recreate the image, and you also see a hiatal area and also measure the hiatal dimensions which can be calculated. And there are studies and data which define as to say the cutoff at which you should take action and do surgeries. So if you look at it, this image, this is a 3D image which is created. And if you look at this circle here, this is an area of levator avulsion. Now, this levator avulsion is being diagnosed because of the discontinuity that you're seeing between the hyperechogenic fibers, the puborectalis, and the pelvic side wall. That is at the insertion, which is being replaced by a hypogenic zone representing the wall. Now, this is something which you cannot diagnose clinically. And this is a patient, no matter what you do, if you don't repair this, you probably not be doing a good job, because this woman will definitely have a recurrence or an incomplete kind of, relief of her symptoms. So if you look at it, this is a 2D image where you have taken pubic symphysis as the kind of reference between the levator and eye, and you look at the urethra and the anal canal with the bladder anteriorly. And when you put in the a 3 or a 4-dimensional ultrasound image, you look at the mid-sagittal plane, and you go on to have the anteroposterior diameter, which is taken by the machine itself. And these softwares then put also, you just not taken in the mid-sagittal, you also rotate in the oblique axial planes at the intersection, and then you create this image in a rendering mode. And after that, with pubic symphysis as a reference, you create dotted lines, and you can see with this dotted line, you get what is called as a hiatal orifice or the hiatal dimensions. Now, this is where you see the anal canal, you're seeing the vagina, anterior the urethra. So in this, you can see that these dotted lines are the ones which are giving the hiatal circumference, and the area inside is the hiatal area. So this certainly can only be created when you have a simple transducer, which is having a 3D imaging in the machine. So to show you this effect, if you can see, this is a woman who has been picked up to have a levator avulsion, as you can see in this asterisk here, which is there when she is resting. Now, this is an image which is showing in the axial plane, which is representing a tear or an avulsion in the puborectalis when the patient is at rest. However, when you ask the patient to contract, that means when she contracts, you can see that there is a complete asymmetry. Asymmetry are in the side which is not avulsed, the side which is normal, shows a good contractility, and you can appreciate the muscle, the pubovisceral muscles of that, the normal size so well, as contrast to the injured side where there's avulsion, where these images show a discontinuity or breach. And that's how you can further confirm that is nothing but a case of levator avulsion. And therefore, this kind of a contractile function is what the radiographer or the person doing will ask the patient and will be able to identify it. So what is the need actually to know levator avulsion on a height or the hiatal dimensions and their functions? Well, clearly, this is a nice study which has come to say that is there a role? And this is a study which looked at 414 patients who were attending the urogynecological clinics, were assessed on the retrospective data, and the 3D, 4D imaging which was created went on to look. What they found was that in this woman, avulsion injury was associated with abnormal levator biometry and functions on the imaging, and that this was the one which was, again, an important factor which was picked up on Valsalva, and this was the one which would tell us that yes, there is a relative lack of or abnormal distensibility, which is showing and was picked up in a good number of patients. Now, what are the implications if you do this diagnosis of levator and avulsion and hiatal hernia? Do we have any role, or is just that it's a new modality and we should use it? Well, we know that it's not being used routinely, but the presence of levator avulsions are associated with increased risk of prolapse recurrence. So if you are mindful of patients, or in a setting where the urogynecological clinics, as you see that paper coming from Australia, this was a clinic which actually has its protocol in place of doing this. They found that the chance of recurrence is lesser. Also, when you're doing this, it is again an indicator to identify which woman would actually be benefiting with surgery or not surgery, but maybe with pelvic floor training. That means with pelvic floor exercise. So if you see a levator avulsion, then there is actually limited role of offering them pelvic floor muscle training, because this will not be helpful until unless you go and repair and do the repair or the surgery of the levator avulsion. Also, the hiatal area that you've seen and you measured If it is going beyond 25 centimeters square in Valsalva, it is identifying as abnormal distensibility, or i.e. is what is called as a ballooning of the levator hiatus. Again, when you have a ballooning, these are the candidates who are definitely meriting surgery as against conservative management. So therefore, now there are some papers which have come up, not the recent, but in the ultrasound journals, which say that there is a good correlation between pelvic organ prolapse and hiatal dimensions of the levator hiatus. Now, moving further to look at how to manage women who are actually having this, there's another paper which actually looks at pelvic organ prolapse and levator ani muscles and looking at is there a benefit and how should you really. So though a paper from China which has advocated and they are advocating the use of mesh repair. We know that of late most centers have done away with mesh surgery, but this is a place where you would benefit in a levator avulsion with mesh surgery. And what they did was they looked at women with stage 3 and stage 4 prolapse, which 95 patients had avulsions of the levator and eye muscles. And when this mesh repair was done, this was seen with a 4-fold reduction in both the objective and subjective recurrence of pelvic organ. So definitely significant improvement with surgery.
Sorry to interrupt, but please wrap up.
Yeah.
One of
Also, the levator avulsions are again, this can be identified. So the conclusion is that in these cases, there is definitely a role of imaging and it helps to repair. Now, let's look at the role of doing imaging, what we do with translabial ultrasound in what is called as coactivation. I think I learned this new term called levator coactivation, in which when you ask the patient to do Valsalva, you will find that there will be definitely a pelvic relaxation and involuntary passage of urine and stool. So what patients do to avoid the embarrassment, they generally tend to contract their kind of pelvic muscles, and this gives you a false feeling that things are nice. In fact, and this is a place where you would like to do imaging and distinguish the dimensions to distinguish whether it's a genuine contraction or the patient is having a genuine, prolapse. So these are, I can't move my screen. Yeah. So these are some of the images where they have done. You can see the woman who was doing a voluntary contraction as called as levator coactivation. But when she was counseled by the radiologist, the clinician told her to relax, you can see that the dimensions are much wider, and that's where it comes. I just can't sort of stop here to say MRI. Yes, there is a place we are not offering. It's a costly investigation. But then there are some, papers which have come up. One from Dr. J.V. Sharma from our own hospital, where they looked at the role of MRI. And of course, there are lines which are called the pubococcygeal line from the pubic symphysis to the coccygeal joint, which are actually helping us grade, and levels being given as mild, moderate, depending on less than 3, 3 to 6, and more than 6 below. Again, a line which is called as the H line, which is going from the inferior aspect of the pubic symphysis to the anorectal junction. And this is also another line called the M line, which is drawn perpendicular. As you can see that there is a pubococcygeal line, which is drawn, H line, which goes between the pubic symphysis and the junction, and an M line, which is drawn. Now, these lines have implication because the PCL line is being used for an MRI grading. Well, I don't think people will offer this costly investigation, but then there's some paper, and for the ICOG fellows, they should know what are the recent developments. So the H line is actually representing that diameter of the levator ani hiatus, which is like normal, abnormal, or mild or severe. And the M line is the one which is used to grade the descent of the levator plate. So these are some of the modalities which are there. Again, some papers which have come up, which have looked at not very big numbers, but they've done this kind of imaging here. And of course, Dr. Sharma has published, but what he found was that MRI was just useful in diagnosing and identifying an interstitial, and that's it, nothing beyond that. So I think you have to be judicious in offering this. I'll again skip this fluoroscopic, but I'll end here that pelvic organ prolapse is definitely a clinical diagnosis. You may not need an imaging, but if you're using a POPQ, which may not be able to identify a defect at distinction, and where you yourself are doubtful, you should use it by a translabial. And then if you're a very, very, thorough person where you feel that you need to avoid a recurrence of a prolapse, or a patient who feel should be, I think a levator avulsion is only picked up. However, should it be a routine protocol to look in levator avulsion? I did not come across any paper. And of course, you can use it when you're doing a translabial to pick up levator coactivation. So I will just end my talk here, that this is the role that I feel is available in today's day for imaging pelvic organ prolapse.
Thank you, Dr. Nina, for your excellent and very informative presentation. You elaborate all translabial, transperineal, and transabdominal 3D, 2D, 4D ultrasound very elaborately. Remember that prevention plays a significant role in maintaining pelvic health. Taking proactive steps such as maintaining a health weight, practicing good pelvic floor habits, and seeking prompt medical attention can help reduce the risk of developing uterine prolapse or its recurrence. Thank you again, Nina, and the organizer for giving me the opportunity to chairing your session. Thank you.
Thank you. Thank you,
Very
sir. I thank all the chairpersons of the second session, Doshi, Dr. Janmajaya Mahapa, Tambe, and all the three speakers, Dr. Rani Singhal, Dr. Nina Malhotra, and Dr. Samir Pradhan. With that, we'll move on to the third. And let me introduce the chairpersons for this session. I'm privileged to introduce Dr. Hafizur Rahman, Professor Obstetrics and Gynecology at Sikkim Manipal Institute of Medical Sciences at Gangtok, India. He's also the ICOG Governing Council member with lot of the next chairperson is Professor Maninder Ahuja. She is the President of Society of Meaningful Life Management and presently a Director at Ahuja and Infertility with 40 years of work to her credit. And she's been the Vice President 2013-2014. Welcome, Dr. Maninder. The next chairperson is Dr. Neeta Thakre. She is the President AOGS 2024-20 Honorary Secretary 22-23. She was the West Zone Coordinator and she's been the FOGSI Chairperson from 2017 to 2019. Welcome, Dr. Neeta. And with that, over the proceedings to the chairpersons, and I request the chairpersons to introduce Dr. Vidya Thobi for her talk.
Yeah. Thank you. Thank you, Dr. Niharia.
Hi, Vidya.
So the talk, yeah, ma'am.
Am I audible?
Yeah, ma'am. You are audible.
Yeah. So
the yes, sure, ma'am. Go ahead.
Yeah. Am I? Can I introduce Vidya?
Yes,
Vidya?
Dr. Neeta, please go ahead.
Yeah. So, Dr. Vidya, good to see you here. She's a very good friend and, of course, very active member of FOGSI. She's president of KSOGA on 23, chairperson of Food and Drug and Medical Surgical Equipment Committee of FOGSI between 2018 and 2020. She received Best Committee of FOGSI Award by Dr. Mehru Hasotia Award in 2020. She is ICOG Governing Council member since between 23 and 25, and she's FOGSI Champion Award, received FOGSI Champions Award in 2019. National Corresponding Editor of Jogi, Organizing Chairperson of KSOGA in 23, and President Bijapur Obstetric and Gynec Society in 2009, and she had been secretary in 2007 to 2007, and she has a lot of publications to her
Sorry
credit.
to interrupt.
Thank
you, but we all know Vidya Thobi.
Yes,
running
yes,
very
yes.
late.
She doesn't actually need
Allow me to share my screen.
Yeah, please.
Please do.
Thank you very much for kind introduction.
Yeah.
Is my screen visible?
Yeah, now it is
yes,
visible.
Yes,
yeah. Full screen.
So, thank you, ICOG team, Dr. Parul, Dr. Sarita, FOGSI team, and my dear friends, Dr. Suman and Dr. Kavita, as well as today's coordinator, Dr. Niharika. This is very simple topic, but very complicated to treat. And I will take only a few minutes to discuss this topic. Now, prolapse of the uterus is commonly encountered clinical condition in Indian setting. It is very rare because, as you know, that the cesarean deliveries are more. So we always blame multiple deliveries or multiple pregnancies or lacks pelvic floor as one of the cause for the prolapse. So it is in India, it is much more common, and there are so many myths related to labor, premature bearing down, maternal malnutrition, and these are the various different etiological factors that underlie this condition. So conception with uterine prolapse makes a lady to stand in the high risk category due to pertaining risk factors such as abortion and preterm labor, etc. Prolapse at the first time during pregnancy is very rare, which occurs in 10,000 to 15,000 of deliveries. And in multiparous, after 2 deliveries, 8 times, and after 4 to 12 times, if she's multiparous, it is more common. So there is various literature reviews which mention that uterine prolapse in pregnancy consists of various case reports when condition was very common due to high parity. So whenever we talk of etiology, again, first comes a multiparity, and we have to differentiate between congenital elongation of cervix, any history of fall, any trauma, or even any neuromuscular disorders, pelvic floor muscle weakness, malnutrition, even obesity, and any history of instrumental deliveries in previous childbirth, smoking, chronic cough, or constipation. So if you go into the pathogenesis, it may not be secondary to simple uterine prolapse. There is a hypertrophic elongation of the cervix is also likely to contribute. And it is exacerbated by pregnancy due to physiological increase of progesterone, again, which leads to the softening and stretching of the pelvic tissues. So one should know about the pathogenesis also. So there is an aggravation of the morbid anatomical changes in the prolapse, hypertrophy, edema, and there is an exaggeration of cystocele and rectocele, and it becomes pronounced. There is again aggravation of stress incontinence, and mainly during early pregnancy due to weight of the gravid uterus and increased vascularity of the pregnancy. Now, there is a copious vaginal discharge. It can be, there is a decubitus ulcer because always cervix remains out of the introitus. There are chances of incarceration if uterus fails to rise above the pelvis by 16 weeks of pregnancy. Now, prolapse and infertility is again common, though we are discussing prolapse in a gravid uterus, because there are various causes like difficulty in intercourse, altered and distorted cervical anatomy, hostile cervical mucus for sperm entry, pelvic inflammatory diseases, and edematous and hypertrophied cervix. These are the common causes of prolapse with infertility. What are the effects on pregnancy? So again, we talk of what are the symptoms and what can happen. So there can be discomfort, pelvic pain, bleeding, abortion, preterm labor, cervical infection, which leads to again fibrosis, and increased incidence of PPROM, chorioamnionitis, constipation, retention of urine, and it may require even catheterization. Now, during labor, there are increased chances of, again, early rupture of membrane, cervical dystocia, secondary arrest, which occurs roughly around 5 when the cervix dilates up to 5 to 6 centimeters, and which was previously managed by Duerson. Even we have managed. I will just describe one case report. And but nowadays, usually we do for cervical dystocia cesarean section. The prolonged labor due to non-dilatation of the cervix and obstruction due to sagging cystocele and rectocele, there are various operative interferences. Now, what happens during puerperium? There is a subinvolution and even uterine sepsis. So this is various journals I just refer into that clinical. There are clinical challenges for the management of vaginal prolapse and especially during pregnancy. So what is the key for the successful treatment is one is early recognition, even first degree prolapse, and we have to give the conservative management. You should give a slight Trendelenburg position with bed rest, and replacement of the uterus after resolution of edema will often protect the cervix from trauma and desiccation and decrease the incidence of preterm labor. Now, about the management, it can be during what you will do during pregnancy, during labor, and during postpartum period. So during pregnancy, the symptoms are pronounced in early pregnancy. So if the cervix is outside the introitus, it should be replaced inside the vagina. It should be kept in the position by ring pessary. We heard a beautiful talk by Dr. Suman Savita, and she has described entirely about the pessary. So I'll not go into the detail of the pessary. So these pessary should be kept till 18 to 20 weeks of pregnancy, when the body of the uterus will usually rise and it will be sufficiently enlarged to sit on the brim of the pelvis. Usually the prolapse gets corrected. Corrected means it goes inside. The pessaries, we know that they are available in variety of shapes, sizes, and there are two main types of pessary. One is support pessary, which is ring and hodge, and the space occupying pessaries like donut and gellhorn. It is preferable to choose the largest pessary that vaginal vault can accommodate. So these are the various pessaries. I'll not go into the detail of these pessaries because of the paucity of the time. These are the usually we use these ring pessaries and without diaphragm usually. And we have to measure from the posterior fornix to the pubic notch and then measure the distance. These are the support pessaries, which are called as lever pessaries whenever there is a urinary incontinence or there is a retro displacement of the uterus. And there are the support pessaries. Now, after placement, the uterus should usually correct itself. Now, ring pessary, as I told you, we have to measure this from the posterior fornix to the pubic notch. Fold and insert like a diaphragm, make 1/4 of the turn, and you have to remove properly. Means you have to do 1/4 of the turn, feel for the notch and pull out. So as I told, the ring pessaries are commonly we do, but before repositioning of the pessary, it should be cleaned with the antiseptic solution. What are the complications of the pessary? Commonly discharge or odor, irritation, and uncommon are the infection, erosions. Rare, almost associated with neglect, is fistulas, bowel, and so much other complications. Even they have noticed sepsis and even the maternal morbidity. So these are the ulcers which are commonly seen on the lateral side. So we have to take care of this rubber ring pessary. When it is very, very lax, then you have to, pelvic floor is very lax. One is three things you should remember, that one is bed rest with the foot and rest. Edema and congestion should be relieved by gauze soaked with the glycerin and acreflavin. It also prevents infection. Continue the treatment up to 20 weeks till prolapse mass is reduced, and then you should allow the ambulation. Reposition, if it is not possible, if there is an incarceration, sometimes because of sepsis and other complications, termination may be indicated. If the cervix remains outside the introitus even later months, then preferable to admit at 36 weeks and terminate. That is the treatment. So these are the three things always we look into. One is bed rest, tampons, and pessary. And pessary, as you know, that it causes pain, infection, dysuria. So you should be very, very watchful for that. Now, this is a novel thing I just went through as Dr. Samir was talking. That is an introital tightening. Of course, in the journal, they have described it for the geriatric patients. This is performed under the strict aseptic precaution. Lithotomy, local anesthesia is infiltrated around the introitus. Tiny stab incision has taken 2 mm at the mid in the posterior fourchette just below the urethra. And then the large curved round body needle with vicryl number 1 is inserted through the incision made on anterior vaginal wall, is passed submucosally in the semicircular fashion, 1/2 centimeter deep and 1/2 centimeter laterally, and then brought through the posterior incision at the fourchette. And similar stitches taken on the opposite side. Now the sutures are tied tighter together to tighten the introitus, leaving 2 finger space at the vulval introitus for the drainage of vaginal discharge and cervical examination. Now 5 to 6 knots are tied here and stitches are buried under the vaginal mucosa, which is then sutured with chromic gadget number 10. Now this is described in one of the journals, which is published in 1997 by Dr. Nandanwar and Dr. Kamini Dalal. And this was shared to me by Dr. Samir Pradhan again. And he has given the reference of Dr. Dani. This they have tried in 55 patients and it was successful. And it is described in the geriatric patient, of course, but he used to do in even pregnancy, in early pregnancy with the prolapse. So there are a series of cases have been published. So what are the advantages? It is a daycare procedure, very simple and safe, done under local anesthesia, and analgesics and antibiotic cream for the local application is given. Now, during labor, if the patient comes in labor, it should be bed. Patient should be on the bed to facilitate the replacement of the prolapsed cervix inside the vagina. Intravaginal plugging soaked with glycerin should be given to reduce the cervical edema, but also it facilitates the dilatation. Prophylactic antibiotics are given and manual stretching of the cervix or pushing up of the cystocele or rectocele past the presenting part during the uterine contractions facilitates the progressive descent of the head. Otherwise, there is a cervical dystocia. Now, if there is a deeply engaged head with thin undilated cervix, delivery by Duherson incision at 2 and 10 o'clock position, and then followed by forceps or vacuum delivery can be accomplished. If the head is very high up, cervix is thick, edematous, of course, we have to prefer cesarean section. This is a case report from my own institute, a case, very young patient, of course. She came with this prolapse and with the obstructed labor, and we could deliver her with Duherson incision. So there are series of cases we have done in my institute. This was, I think, third or fourth case. The pregnancy and prolapse usually they deliver easily, but the monitoring is very, very important. Now, after delivery, this suturing should be done on both the sides. There are so much literature is very scarce. Only there are case reports and case series which are available on pregnancy and prolapse. So this literature review shows that the majority are delivered by normal vaginal delivery. In 2007, Daskalakis, he suggested the elective cesarean section near term to avoid further pelvic floor damage, especially when the cervix is edematous and elongated. The cesarean section near term could be the safest, again, delivery modality in order to avoid progression of prolapse and uterine rupture. Sometimes the patient comes very late with obstructed labor and because of cervical dystocia, or if there is a rupture or any damage. So pregnancy who have completed their families, and some of the authors like Medellini, they have suggested evasive approach of cesarean hysterectomy with vaginal cuff suspended to the periosteal oval and the sacral promontory after the procedure. So more of the state of art, I will take only 1 minute, was described by the other authors to who performed this laparoscopic uterine suspension in early gestation when the patient is in the first trimester. So these are the various literatures which are available, but they are not proven and not recommended. So during preperium, patient should lie flat in bed. If the mass is still outside, cover with gauze of glycerin and acryflavine. If there is a sub-involution, ring pessary till involution, prophylactic antibiotics, and after 3 months, if surgical repair is required, you can go. So one should always insist in all women, perineal exercises, high protein diet, iron, multivitamin, and calcium supplementation. Avoid strenuous activities that lead to the state of high intra-abdominal pressure, treatment of chronic cough and constipation. So prevention is always we talk of prevention and limiting injury to the pelvic floor during childbirth, avoid prolonged labor, proper suturing of episiotomy and perineal tests, encourage early ovulation, and you should always teach the woman the Kegel exercises. So this is my take-home message that the management of pregnancy associated with uterine prolapse is highly individualized. It varies according to the symptomology, clinical findings, age, and reproductive status. And it is very difficult to manage primary PPH in these patients because many times it cannot be reduced and we cannot do proper massage or bimanual uterine completion. So we have to be very vigilant in this patient, especially for the infection and other complications. Thank you very much for the opportunity, and thank you very much for the patient listening. Thank you very much.
Very nice presentation, Vidya madam.
Yeah, Dr.
An
Vidya,
eye-opener.
it was
Very nice.
nice presentation.
And I must thank Dr. Haresh Doshi. Actually, mine was not uploading, but I could upload it. But he also sent his presentation also. Thank you very much.
So thanks to both Dr. Haresh Doshi and both of them for this wonderful presentation. I think because there are no questions in the chat box and we are running short of time.
Thank you, Maninder. Thank you, Dr. Maninder, Dr. Hara, I can see here. And Dr. Neeta, of course, my dear friend. Thank you.
Excellent presentation, I must say.
Thank you, thank you, thank you, Neeta.
Yeah. Good to see you.
Ma'am, I request the persons to
Maninder ma'am,
introduce
are you-
Dr.
Okay, should I introduce Dr. Patnaik?
He doesn't need
yes.
introduction, basically.
Dr. Hara Patnaik, he doesn't need an introduction. Of course, he doesn't need because he has been going so much, I think, practical surgeries he has done. So he was vice president of FOGSI along with me when I was the vice president. And he's president of Association of Obstetrician and Gynecologist of Odisha, governing council member of ICOG, national corresponding editor of FOGSI Journal, chairperson Geriatrics Gynecology Committee, FOGSI. He was senior to me, ex-special secretary, Health and Family Welfare, Odisha, and ex-director, Health Services, Director, Public, Odisha. Dr. Hara Patnaik, it is a privilege to have you here with your presentation, please. How to prevent the prolapse of hysterectomy.
Thank you, Maninder, for those kind words. And I think it's a privilege to be introduced by Dr. Maninder Ahuja. And thank you very much. Thank you, ICOG, Dr. Suman, Dr. Niharika Allu, and my boss, Dr. Rajendra Saroghi is already over here. And sir, namaskar. And it's a Dr. Saroghi is a emblem of teacher and training and all these things. I will like to share my screen and I think, are you able to see it? My screen?
Yes, sir.
Full screen हुआ?
नहीं, हाँ, हो गया. हो रहा है, sir.
हो गया?
sir.
Thank you. So, blessings of Lord Jagannath. And I will be speaking on ball prolapse, a practical approach. Okay. So, see, what we call vault prolapse, it's a de novo descent of vaginal vault through introitus. For any reason, if the vaginal vault has fallen down, given in, and descended outside vagina or inside it, it is a vault prolapse. Usually, vault prolapse is followed by following hysterectomy, and sometimes in few cases, it can be a congenital vault prolapse also. And the main thing which we should know, pathogenesis or leading causes, is weakness of the supporting ligament which supports the uterus after hysterectomy, support the vault. Second thing, a raised intra-abdominal pressure will aggravate the situation more, and so that it proceeds further and further. So the types of vault prolapse, what we say, the number one I'll say is a post-hysterectomy vault prolapse, which we see in large number these days, as because large number of abdominal hysterectomy, vaginal hysterectomy are being performed in many places by many surgeons and gynecologists. Number two is a nulliparous prolapse. Nulliparous prolapse is an entity by itself where there is descent of the uterus from the normal place of attachment, and this is an entity itself. And third one will be an enterocele early, and this will be the third entity. So the cause of vault prolapse, we say the first thing to say is an ill-chosen and ill-done operation. So if it is not, the remedies are not taken properly, this will be telling that the operation is not properly performed. Let's say the patient factor which has aggravated this is because the patient is generally debilitated, malnourished, severe anemic. This will lead to vault prolapse. And in post-menopause, we all know there is a estrogen deprivation, and the effect of estrogen deprivation can further aggravate the laxing of ligaments and descent of the vault. And most important and last but not the least, in the deep peritoneal pouches, the anterior pouch and the posterior pouch, if they are deep, there is a definitely there will be a vault prolapse. The physician factor or the gynecologist factor is to recognize the pre-existing defect. If there is already a small cystocele existing and you have overlooked it and performed only the hysterectomy part, this cystocele will aggravate subsequently and there will be anterior defect. Failure to address the vault support. The vault has to be supported by both sides or in the center or to the sacrospinous ligament or to the uterosacral ligament or to the sacrum in different way. And the most important thing is the defective surgical techniques, what we always say. The treatment option we offer for a vault prolapse is a number one and first and foremost, I'll say expectant management. If the patient does not have any symptom, there is a descent, but the patient does not complain anything, it's better to watch and observe rather to offer any surgery. So it is always an expectant treatment, follow up her. And the second thing what Dr. Thobi has told about use of pessary and so that is a non-surgical approach, extremely thin-built women, extreme old age. It's an option for delay the surgery or where you are not thinking of surgery. And the third one is a surgical option, which we will be thinking about it. Please remember that if you are doing a surgery and the vault prolapse, and first of all, there will be a relief of symptom because there will be a cystocele, there is a rectocele, and that's the main thing. The relief of symptom will be there, and you have to restore the anatomy of the pelvic organs as far as possible. Anatomical replacement will be needed. Restoring the horizontal vaginal axis and the length of the vagina. It is very important. The vaginal axis has to be maintained and vaginal length, adequate vaginal length is required following surgery, because today more and more elderly women do need sexual relationship and they have an unmet needs. Restoring the bladder and bowel function, enabling satisfactory sexual function, and you should see that there is no prevention, no recurrence, so that prevention of recurrence, minimizing complication. And the principal surgery I would like to say, the first and foremost is the 3 compartment, and you should address the defect. The apical one, the anterior one, and the posterior one. These are the 3 defects what we will see in the center, anterior and posterior. This thing very, very important. So anatomical suspension of the vault to a ligament is essential, and addressing the hiatus urogenitalis or hiatus rectalis, and concomitant procedure you can do. So surgical options are many, and I will be speaking about the vaginal approach. So we will be repairing, addressing the defect, and where to suspend the vault. This procedure, you have 2 options. One is a sacrospinous fixation. The one which I promote is a uterosacral suspension. So if you see, you have to suspend or fix the vault to a ligament, or we say the sacrospinous ligament, so that in sacrospinous ligament, please see the position of the ischial spine is at the level of internal os, and the vault in a non-descent uterus is much above the internal os and much above the ischial spines. So the normal position, the vault remains at a higher position than the ischial spine. So when you fix the vault after surgery to the ischial spine, it is placed at a lower level than the normal anatomical position, pre-existing position. Number 2, you are fixing it to the uterosacral ligament to one side or other, so that it is tilted, the apex is tilted to one side, preferably to the left side, right side of the patient and the left of the surgeon. So that is very essential. That is why the second one which we propose is uterosacral suspension, which remains high, it remains much higher level, it remains in the center, so there is no tilting to this side and that side. And addressing the hiatus, we will be offering colpoperineorrhaphy and levator ani apposition, so that the anterior and posterior repair is performed well. Well, those people who are elderly people, not able to stand surgery, you can offer them colpoclasis. Mesh repair is out of discussion now. Of course, some centers, they do autologous tissue repair, but we will be discussing the surgical option to on the vaginal approach. Well, there is a laparoscopy approach where you do a mesh colposacropexy, use a suture or a tucker, and the laparotomy or abdominal method. Here also you do a sacrocolpopexy. It's a mesh with a suture and cover the mesh with a peritoneum so that it remains retroperitoneal. The purpose of all the three procedures is to give a patient a better quality of life. It does not matter whether you do a laparoscopy or a laparotomy or a vaginal route, but it should be simple, it should be beneficial to the patient, and that is my aim. And this is a huge world prolapse, and the entire thing which I will be discussing, this is operated, and I will start with the surgery. You see, the surgery is the same. Please close your eyes and think the way you do a ward myohysterectomy. So you give a three allies. One is below the external urinary meatus. The two others are the most dependent, and two on the two lateral side. And you give a triangular incision, peel the anterior vaginal mucosa and vaginal mucosa very quickly if the line of cleavage is properly made and there is very little tissue in between, and there will be very little bleeding, and it will peel like a cloconate stump. This will be extended posteriorly, and if you extend it posteriorly, you can see that a rhomboid incision is made, and this has to be separated from the vaginal mucosa, is separated both anteriorly and again in the posterior side. Now that, please be very gentle, because bladder in the front, bowel in the posterior side. Now, second thing is to separate the bladder from the lateral vaginal wall. The same way you separate the bladder in a ward myohysterectomy. The thing is that you can use a knife or you can use a scissor, and that is the first important thing. That the second thing, please take care that the proper line of cleavage is cut. If you get the proper line of cleavage, and you can very well separate it. Now, when you separate the peritoneum from the posterior side, you can, when you are separating it from below, and you cut open the peritoneum, and you see the peritoneum is now open. So when the peritoneum is open, you can widen it a little more. And the thing which you are seeing, you can see the neck above, and I will show that if you pull it down, the two uterosacral ligament will be very clearly visible on the two sides. They are the rudimentary thing you can see over there. So that put a sim speculum, and you can retract the anterior one and retract the posterior one. Identify the uterosacral ligament. They are top structures. They are on the lateral side. Usually they remain in 5 o'clock, and this side is a 8 o'clock position, and you can identify. We always use a Vicryl number 1 to close the vault, and you should go as this is the uterosacral ligament on the on your left and the right side of the patient, and go as high as, when you are closing, go as high as possible, and take the peritoneum at the neck of this. So you can do that take a posturing suture from all around, which I am taking this side, and you go, please do not take a very deep bite. Take on the peritoneum. The thing is that the catch is that you are taking the bite from one uterosacral ligament, going to the center, taking a bite from the peritoneum from this side, going to the uterosacral ligament on the other side, then going as high as up to of the neck of the prolapse, and then you are tying this. See, take a long thread and tie this in the center. What is there in this? You have taken a posturing suture, taking the two uterosacral ligament on the both the sides, and you have fixed it with a thread. And the thread is kept long, and this will be tied outside the vaginal mucosa as you tie in a ward myogystectomy. Now, now that you can see, this next job for me is to repair the bladder, the anterior compartment. So what we do, this is quite big. So first of all, we take a posturing suture all around the bladder with a serosal layer of the bladder fascia. So some people say that if you are taking a posturing suture.
Sir, your time is up.
Time is up?
Yes.
Okay. Madam, I am taking a bite from alarm. When this is done, you can press it inside. Can I finish this video? Another 2 minutes?
Yes, yes.
So, this is what I wanted to say, that you take you have taken this all around, and once you try to push the bladder inside, right, and tie it in the center. So the bladder has gone inside. Many people say that there is a theoretical possibility of a retention of urine if you do a posturing suture, but in fact it is not there. It is the long-standing bladder which is staying outside can cause this, and in such a case you can put a catheter again for 3 weeks, what many people say. Now the second thing is that to stitch from side to side, and the bladder is, from side to side, and you are stitching this sheath paravesical tissue from both the sides, and then this is complete by intermittent stitch with same vicryl number 1. And when this is done, so remember those 2 long threads which you have kept earlier. So take them out with the cobbler's needle. It has got an eye, and the eye is half open, so that you hook the 2 threads, and that is done. And now your repair will be from above downwards. Do not unnecessarily cut too much of vagina, because vaginal mucosa cannot regenerate. So whatever amount is required, cut as minimum as possible, and then you forward further. So here I am, the closing, the starting from up to down, and the repair. I just wanted to show the vaginal length at the end of this, and this can be taken as a continuous suture. So below downwards, some people use lock. Many people do not like to lock, but this gives a better strength, and this also prevents hemorrhage in a postoperative period. Now that, well, so can you see this is almost complete, and after this I just wanted to show only that you tie the thread which has come out, tie the thread which has come out, which is now hanging there. So you can see that my closure of the anterior wall is complete, and I will like to push the vault further, and this is done. Well, this is a very, very simple method, and your vault will, now that you tie it, remember that this is the two threads which have been held by you, and you are tying it in the center and push it as high as possible. It goes up, and 1, 2, and 3 stitches, and the vault is going up, but you have to complete the procedure by a perineography. Unless you do a perineography, the vaginal length will not be maintained. So take 3 alleys from the side and put the upper one in the midline just below the incision, and cut open the thing, and mucosa in the mucocutaneous junction, separate them, go as high as possible, and strip off the extra length of vaginal mucosa there, and yes, from one side to other, the perineography is done by all of us, and we know the steps is very easy and simple, and it's the basic thing which we all know. And this length, triangular flap of vaginal mucosa is removed from one side. The same thing is repeated on the other side, and so this is the same step with for posterior colpoperineography, which you do in a ward hysterectomy and all the steps even in a FOGSI repair. So now that the apposition of the levator or the muscle to the midline. So same vehicle number 1, earlier we were taking number 2, but stitching from one side to the other can be done. Take a bite, and
Sir, sorry to interrupt. Can you
yes,
please
I think
wrap up?
that is all. I just wanted to show the vaginal length after the perineography. You can insert 2 fingers over there. That finishes my presentation. I think I will stop here. And these are the 2 tips to say that how you prevent vault prolapse if you are doing a surgery. I have no paucity of time. I'm not going to show them. And this is one. When you do a vault closure, you have to fix it to the uterosacral ligament on the 2 sides after doing a vaginal hysterectomy and closing the vault. That is the tip and trick which I wanted to give, that it will prevent vault prolapse if you are doing it, performing it, fixing the ankle and the center to the lateral wall, and we do it in same procedure in the most of the cases. Thank you very much for a patient hearing. Sorry for overshooting the time, and I think I stop here, and if you have any questions to ask, I can take it, or we can talk in a separate day because of paucity of time.
You can answer the questions in the chat box, sir. That was a wonderful and excellent presentation.
I can do that. Thank you.
Presentation, sir.
The surgical procedure shown was excellent, sir. And video was very, very clear as well. So everyone could appreciate it very well. Sir, your presentation was really good. And the tips that you said in the end, that when you suture uterosacral ligament with vault, that serves the purpose. Thank you, sir.
Thank you very much.
And just one thing, it's very devastating for the women, because in Punjab, they used to say, jab ladies will come, they'll say, hamari chhat gir gayi. So initially, I could not understand what the chhat gir gayi meant. So prolapse for them is just like a chat falling down. So I think Dr. Hara, you have covered it very nicely, especially bringing the length of the vagina back and tying up the uterosacral to the.
Thank you very much. Sometimes
Thank you very much. I think we have the best for the last. So can we have Dr. Hafizur introduce Dr. Rajendra Sarogi, sir, please?
Hafiz?
Dr. Hafizar is there?
I just saw him.
Yeah, I am there. And,
yeah, he's there.
So good evening, everyone. Thank you, ICOG and Dr. Niharika, for giving me this opportunity. It is an honor to introduce Professor Dr. Patnaik. Already told he is the teacher of teachers. So, sir is Emeritus Professor, Seth GS Medical College and KEM Hospital, Mumbai. and ex-honorary and HOD, Dr. R. N. Cooper Hospital, Mumbai, Senior Consultant, Nanavati Hospital, Mumbai, Director, Saraugi Group of Hospitals. He's patron and founder
Sir,
member
you
of
can stop it
Association of
now. Sir, you can stop it now. It's enough.
Yes, so it is, sir, without wasting much time, I would like to request Saraugi sir, sir is going to speak on colpoclasis, which is very much an essential procedure, at least for some of them, and I am sure the delegates will get an insight on this. So over to you, sir, Saraugi sir.
Thank you, sir. I am thankful to the ICOG office bearers. Special thanks to Dr. Suman and Dr. Kavita for inviting me to give a talk on colpoclasis. Respected chairpersons, my talk is on colpoclasis. It's divided into two portions. First will be some slides and followed by a live surgical workshop which I had conducted, in which I had demonstrated Liffords colpoclasis. Can I have the first slide, please? Suman, can you tell the
Yeah. Support system is there.
ICOG team, can you please share sir's presentation?
Just a minute.
Yes.
The video presentation which will be shown is a live workshop which we had conducted in Mumbai at AFG. That time I had performed this surgery and we had taken a video, and that is the one which I am going to show. I think
Shall I share video first?
No, first you share the
PPT, yeah.
even Hara had attended, PC has attended, so many of them have attended. Yeah, go ahead, next slide, please. Make it slide presentation, slide show. Yeah. See, instead of making it colpoclasis, I have made it obliterative procedures which are done vaginally. It can be Liffords colpoclasis, it can be Goodall Powers modification, or it can be Dani stitch. Next slide, please. What we mean by colpoclasis? Colpoclasis in meaning is vaginal closure. It's a surgical treatment option for pelvic organ prolapse in which length of the vaginal canal is shortened. It is performed per vaginum and does not require any incision on the abdomen. Next slide, please. Let's talk about Liffords colpoclasis. It is being done in women who have severe medical disabilities like uncontrolled diabetes, hypertension, heart problem, which makes it any major surgeries and anesthesia hazardous. The advantages are it can be performed under local anesthesia, or if you feel that you are scared about her heart condition, you can go ahead with Xylocard. It's very simple. Previous slide, please. Previous slide. Yeah, it can be performed rapidly, gives good satisfactory results, can be performed with third-degree uterine descent. But mind you, there has to be a good amount of cystocele and rectocele. It can be performed in cases of procedentia. It can be performed in wall prolapse repair also. Next slide, please. Contraindications are intact uterus who is not menopausal. That's one of the most important thing. If cervix is bad or there are uterine pathology, please don't go ahead with this. And if patient wants to have sexual function, please don't do this surgery. The disadvantages are it can result into stress urinary incontinence, which occurs in almost 31% of the cases, and hematoma. Next, please. Technique of the operation. Original Liffords operation included making raw surfaces 4 cm. What's happening now? Please.
We're not able. Can you reshare? Yeah.
Make it slideshow, please. Yeah. Original Liffords operation included marking raw surfaces 4 cm in length and 2 cm in breadth on both anterior and posterior vaginal walls, which you will see in subsequent video. The raw areas were joined beginning with ends close to the cervix. The reduction progresses step by step with placing of the sutures when two surfaces are united throughout reduction is completed. Next, please. Ancillary surgery which can be performed along with this are You can do perineoplasty. You can do Cayley stitch or mesh plasty, TVT, TOT, particularly to prevent SUI which can occur following this surgery. Next, please. If you look at the allography, A stands for after menopause, B is blood loss is negligible, comorbidity like diabetes, heart disease, hypertension, unfit for anesthesia. Damage to adjacent organ is practically nil. It's very economical, fast recovery, no failure. It's excellent, a good operation. Hospitalization is for 1 to 2 days. Next, please. I stands for instruments which are practically nil. No new instruments are required. Your alices and arteries are more than sufficient. It's a Juna technique but forgotten by all. Knowledge is first poster can do it. Low morbidity, local anesthesia is sufficient. Mortality is nil. Ideal patient is menopausal. No pain, good for obese patient and old age. Postmenopausal, and it's practically painless. Next, please. Quick recovery, recurrence is practically nil, no scar, sexual function not possible, SUI can occur, and simple underutilized operation. Time can be done in less time. Understanding is very easy, very effective. Working gives more satisfactory. Wound infections are practically nil. Next, please. Goodall-Powers modification of Liffords operation, which was performed in 1937. It can be performed in patient with intact non-pathological uterus. A triangular area of vagina is marked about 2 cm above the cervix, the apex of the triangle covering about 1/3 of the length of the vagina. Sufficient space is left laterally to allow for drainage of cervical secretions. This area of vagina is denuded of mucosa. Same step is repeated on the posterior wall. Mucosal edges of triangular bases are approximated with 1-0 Vicryl. It's something like partial Liffords operation. Next, please. Further closure of denuded area is done as in Liffords operation. Thus, the obliterated vagina forms a kind of shelf on which the cervix rests with satisfactory drainage of cervical secretions, or even the resultant vagina is short but functioning and it's satisfactory. Patient with cystocele and rectocele require repairs in the usual way. Cystocele repair is done before tying the lateral surface placed over the denuded area. Next, please. Advantages: vagina is functioning, satisfactory. 1/3 length of the vagina is preserved, so sexual function is performed. Disadvantages are cystocele and rectocele are to be repaired separately. Next, please. Let's come to Dani stitch. Dr. Suhas Dani from Government Medical College, India performed this operation for the first time. It was published in Jogi in 1989. It is called as introital tightening like Thirsius stitch for rectal prolapse using Sutupac. The advantages are less tissue trauma, decreased bleeding, no SUI, pap smear can be taken, and free drainage of vaginal secretion. Next, please. Now, can you go ahead with the video?
Yes.
Give a voice, please.
Share sound also.
Yeah, share sound. We had performed at Cooper Hospital. Laffords colpoclysis or Laffords repair is generally being done for 3rd degree uterine descent with healthy cervix in a postmenopausal woman who doesn't have any uterine pathology. What's happening?
Say okay to that. Message came that it may be inappropriate for users. Can you reshare?
Who will do okay? The support system will do, na?
Yeah, they're doing. ICOG team?
Oh. Yeah, restarting.
Double click, I think.
It's
And
not starting, ma'am. It is not going further.
Okay.
I'm not able to click anywhere.
Okay. I saw it yesterday only.
Can we access the same thing online right now?
Yeah.
And it will say the same thing.
You can go on YouTube and immediately.
How they will do, ICOG team? Tell us some solution.
Just
Yeah, we are waiting.
Share again, I think.
Incision line on the anterior surface.
Double click करने से हो जाएगा.
It's
Yes,
coming.
no.
Yeah.
Lafort's colpoclysis or Lafort's repair is generally being done for third degree uterine descent with healthy cervix in a postmenopausal woman who doesn't have any uterine pathology. After taking the labial stitches, we demarcate the incision line on the anterior surface. Similarly, demarcation is being done on the posterior surface. Either you can use a marker pen or you can use methylene blue. After demarcation, if there are no contraindication to use saline adrenaline, one can use saline adrenaline diluted 1 in 2 lakhs, or only saline can be used to demarcate the planes. You can inject anywhere between 80 to 100 ml of normal saline. After doing that, the incision is taken first on the posterior aspect where you have demarcated the incision with the help of methylene blue. The reason why we take on the posterior aspect is because if there is some bleeding and you operate on the anterior aspect, the blood keeps spilling and in the operative area. Gradually peel off or do a sharp dissection and separate the entire vagina, which is in a rectangular form. After cutting the posterior vaginal flap, now we excise the anterior flap. Anteriorly you have to be little careful because bladder as well as the urethra comes over there. If you look at it, you will realize that on both the sides I have kept little vaginal flaps which acts as a tunnel. In case any discharges occur later on, it can come out through these tunnels, which you will see in subsequent surgery. A gradual dissection of the anterior flap is being done, gradually separated from the bladder as well as the urethra. If you have injected properly in proper planes, you will find literally you can peel it off. See here, you can see the anterior flap is being peeled off. Once that is being done, you will realize that you have anteriorly raw area as well as posteriorly raw area with vaginal mucosa on both the sides. Now gradually we will take stitches, maybe 3 or 4, and convert this into a tunnel. We don't tie the stitches, we hold it initially. This is practically unedited video. When you take lateral stitches, you see to it
Time is
that
up, sir.
you form a tunnel laterally.
Hello.
Yeah.
Your time is up.
Now we pass either a rubber catheter or you can pass a polyethylene catheter. This is just to maintain the patency so that later on, once the catheter is being removed, you will find that whatever secretions which come out from the cervix will
Can we
come
have
out of
post
these
test in the chat
tunnels.
box?
Now we tie up these sutures which we have taken.
Niharika, by the time video is running, can we give link of post test also?
And we hold them properly.
I have to leave the screen for that.
Okay. Without that, it is not possible.
Yeah.
They need to share the QR code, Namam.
These sutures act as support. See here, you can see the movement of the catheter nicely. Now we are taking sutures through the fascia over the bladder. You can move as well as on the posterior vaginal raw area,
Be a little
gradually
faster
covering
because
the areas.
other doctors are waiting for the post test.
Now whenever you take stitches on these
Should
raw
I stop the
areas,
video or
you
fast
try to
forward?
take
Fast
it
forward, fast
in a
forward.
zigzag manner.
Sir. All
Fast
the
forward.
doctors are waiting for the post test.
Yeah, fast forward.
If you see a wall being
ICOG, can you do on
constructed
your side fast forward?
and the bricks are being placed, they are never put in one line. You will always find that they are being put in zigzag manner. Similarly here, while taking stitches, we try to put stitches in a zigzag manner so that no raw area is left behind and hematoma formation does not occur.
You can go
You
still
may have
fast
to take
forward.
many such serial stitches in order to cover the entire raw area anteriorly as well as posteriorly.
As such.
And when you take stitches, you have to understand how much area is being left behind, anteriorly or posteriorly, and depending on that you can take more stitches anteriorly or more stitches posteriorly.
You can see how it's getting reduced automatically.
We were using catgut, nowadays we use vicryl sutures. It may be number 1 or 10 vicryl sutures.
You can
on
go
a round
still
body
fast
needle. You
forward.
don't have the patency of the passage. They are coming nearer to each other.
You can show the last part now.
Drag the cursor closer to the end.
See how both the anterior.
Yeah. No. Right.
But still there is a gap. So probably we will take some more interrupted sutures to obliterate this gap. If the operation is being done under local anesthesia, then you can use xylocaine, which is diluted, as an infiltrating medium. It will serve both the purposes. In that case, there will not be any additional xylocaine required. See here how both the edges, anterior as well as the posterior vaginal edges, have come nearer to each other, and we take interrupted sutures and close it and remove the catheter, and the surgery is over.
Thank you.
Sir, people are asking about the link of your YouTube.
Yeah.
And put it in the chat box so that they can view.
They can go to Dr. Sarogi's Leafort operation, Leafort scalpoclysis. There are many operations which are there on my YouTube.
Okay, sir.
Sure, sir. Sure, sir. Thank you so much.
Thank you.
Thank you.
And for
Thanks
such
a
a
lot for
wonderful
giving me this
presentation.
wonderful opportunity.
Yeah.
Thank you,
Thank
sir.
you so much, sir. I think we should move forward without taking any.
Yeah. Thank you so much, all the chairpersons of this session.
Thank you. Thank you
Dr.
to ICOG, everybody. I didn't thank them.
Thank you, madam, for being with us.
Chairperson, everybody, all the speakers, all the chairpersons. It was a nice, I think, presentation. Niharika and Archana and Dr. Vidya Thobi, Dr. Suman Sinha, everybody has done wonders.
Thank you, madam, for being with us.
Thank you, ma'am.
I think we'll take
So with that, we of the academic session, and we'll post the post-test link right now. And before the post-test, I want to make a small announcement. On day one, one topic was left out, Dr. Mandeep Pal, on how to assess a woman with urinary problems. So this session will be done tomorrow on day 3 by 3:30. So all the delegates are requested to log in at 3:30 sharp for that. Thank you. So can we have the post?
Yeah, please share the. Yeah. Also in the chat box, the link.
A question about the timer. The timer is right above. You can actually see screen. At the top, you're able to timer. On this, it will not be visible on the link. It will be seen in this Zoom presentation.
So be fast.
Yeah, there are 20 questions. And
So
we'll be sharing the answer.
Link is there in the
10-minute
chat
period is
box
over.
as well.
Yeah,
20 question, 10 minutes.
Yeah, the post test has been shared. You can scan the code if you're using a mobile phone. If you have a mobile, you can just go to the chat box, click on the link, and it will open. It's already being access that. 3 minutes are over, 7 minutes to go. Only 4.5 minutes left.
Dr. Samira, timing is on the top of the screen. It is visible to us.
And it is visible to everyone actually. And don't bother about timing. Just go on putting your.
I think they are expecting the timer to be there on the Google form.
No, no, it is on the, what to say, screen. Top
Zoom
of the
screen.
Zoom screen. Yeah.
2 minutes left.
2 minutes left, yes.
Good. Many of them have finished also. Good. Garima done.
Please join tomorrow as well.
Yeah, yeah. We will tell the answers.
Yeah, we are telling the answers. Please be there. Then only you can check your own scores.
Final score will
And
come
we need 50% all the 3 days to get the certificate.
Are we supposed to give the final score tomorrow? Is there some?
Ma'am, they'll get, like the ICOG will have the access to it. We will not.
They will do that homework.
Because they are asking for the score, therefore I asked.
No, 50% is okay.
45 seconds. Please hurry up, because after that, even if you want to submit, it will not accept it. Last 30 seconds.
Please be there because Dr. Suman will tell the answers. You can check yourself where you went wrong.
Many have submitted. So,
Sir,
time is up.
I request Dr. Suman Sinha to tell us the
I
answers.
also request you to
share the
display on the screen the answers.
Team, can we have the?
I request all the delegates to make their videos on so that we can see them.
Yeah. So participants, thank you very much for your participation. I hope you have done well. So coming to the answers, so you can check yourself. Which of the following, question number 1, which of the following statements, oh, again it's gone.
Just a minute.
So please stay back and see the answers. All the doctors who have participated. Yeah. So the answer to the question number 1, the question is, which of the following statements are true about non-hormonal treatment for genitourinary syndrome of menopause? The answer is A and B. Now, answer to question number 2, all of the following are true about use of vaginal estrogen to treat GSM except is rates of endometrial and invasive breast cancer and DVT are significantly increased with use of vaginal estrogen. Next, please scroll up. Yeah, answer to question number 3, which of the following is not an indication for use of pessary? It is prolapse with vagina. C. Now, answer to question number 4 is all of the following are complications associated with pessary except C, that is the reduction of prolapse. Answer to question number 5, what is the modern non-invasive approach for anterior vaginal prolapse? Answer is C, that is laser. Question number 6, cervix is anchored to anterior superior iliac spine in this surgery. What is that? Answer is B, Khanna sling. Move up. 7, the surgery is performed vaginally in Virkut's composite sling, Sirotka sling, sacral hysterectomy. Answer is D, Fothergill's Manchester repair. 8, Sirotka's abdominal sling constitute the following steps except answer is C, advancement of uterosacral ligament to anterior lip of cervix. 9, Which imaging modality is useful for UV prolapse? Answer is B, translabial ultrasonography. Scroll up, please. 10. What is the definition of abnormal distensibility or ballooning of levator hiatus on US imaging? Answer is A, hiatal area of more than 25 centimeters square on Valsalva. 11. Which statement is incorrect as regards to levator coactivation? Answer is G. It is evident as an increase in the mid-sagittal hiatal diameter on Valsalva maneuver. 12. Following is not a posterior vaginal wall defect. Answer is A, enterocele. 13. Which of the following regarding uterine descent is not correct? First degree descent implies the cervix descends below its normal level on straining and protrudes from vulva. B. Next, please. 14. Which of the following is not an obliterative vaginal procedure? Answer is D, Fothergill's repair. 15. Leiford's colpoclysis cannot be performed in which condition? Answer is D, second degree uterine descent within cystocele and rectocele. 16. Main disadvantage of Leiford's colpoclysis procedure is answer D. Chances of SUI occurring is very common. 17. Following are true for management of prolapse except C. Vaginal hysterectomy is the only treatment of prolapse in all women. 18. Management of third degree prolapse in a 27 years para 1+0 can be all except answer is A. Vaginal hysterectomy. 19. Scroll up, please. A 50-year-old multiparous woman comes to OPD for symptomatic vaginal bulge. Her POPQ grid after examination is as follows. Answer is, what is the POPQ stage? Answer is D, stage 3 for all compartments. Number 20, enterocele results from defecting. Answer is A, level 1 support. I hope you all have seen your score and the answers. Thank you very much for your participation.
You have all scored very well because I think there were a lot of simple also. All you needed to do is listen to the talks. So thank you all the delegates for being here. Suman said the concluding remarks.
Thank you, Niharika. So on behalf of Vaginal Surgeries and Urogynec Committee, I extend my heartfelt thanks to all the dignitaries, faculties, and participants for joining us today, which was dedicated to genital prolapse. At the outset, I thank our chief guest, Madam Alka Kriplani, guest of honor, Dr. Parag Viniwale, our President FOGSI, Dr. Jaideep Tank, and Secretary General FOGSI, Dr. Madhuri Patel, ICOG Chairman, Dr. Parul Kuttawala, Vice Chairman, Dr. Sheila Mane, Secretary ICOG, Dr. Sarita Bhalerao, Series Convener, Dr. Charmila Ayavu, Dr. Parag Viniwale. I thank all the speakers and chairpersons for very meticulously preparing the topics and inputs by our chairpersons. I thank the co-convener, Dr. Vidya Thobi Madam and Dr. Kavita Barnowal for her support, and all the coordinators, my dear Dr. Niharika Alu, Dr. Meera Raghavan, and Dr. Meena Mahalingam for shouldering our responsibility so well. Thank you all the participants once again for your active participation. Thank you very much.
Thank you. Good night.
Good night. Thank you, madam.
Good night, and please join tomorrow in time. Again, don't ask for pre-test again and again. So for pre-test and post-test,
in time 3:30 tomorrow 3:30.
You have to join early and listen to the last talk also, which is very interesting, which was not
Sarogi sir's
yes, Sarogi
YouTube link has also been shared in the by ICOG team in the chat box. So whoever is interested can call. It's there in the chat box.
I request everyone to give the feedback on this certificate course to the ICOG office. How it was, what improvements and what other talks you need. So that next time we can include them. Thank you.
ICOG team, can Dr. Meena?
Network.
Yes, Madam, I unmuted her.
Yeah. Let after that this link is over, just we can have 1-2 minutes for tomorrow's program. once everybody leaves the dais.
So, Dr. Meena is calling me. Meena Mahalingam. I will call her.
But
Madam, just
Yeah.
want to discuss about tomorrow's topic.